ശരി. Good morning, Anuna. കേൾക്കാമോ?
Good morning, ma'am. കേൾക്കാം.
ഒന്ന് നോക്കാൻ വേണ്ടിയിട്ട് ഞാൻ ചോദിച്ചത്.
ശരി മാം, കേൾക്കാം.
Good morning, Srila ma'am.
Good morning, Epan sir.
Good morning. Good morning. Good morning, Anuna. Good morning, Dr. Ravi.
Sir.
Dr. Ravi, you're not audible actually. Can you just try your mic once again? It's muted now. It's muted now. Yeah. Please say again.
Am I audible, sir, now?
Yeah. No, it's audible. I think you have to hold the mic piece towards your mouth. The distance.
Yeah, am I audible now?
That's best. That's a perfect thing, doctor. That's best.
I'm audible, right? Yes.
Perfect.
This is Leela here.
Good morning, Sudha, ma'am.
Good morning, Sunil. Hi, good morning.
Good morning.
Yeah, that's it. Now we have specialties, all three specialties persons here in Pushpagiri. Good frame for a screenshot with the faculty and moderator also. Sunil, Anuna, myself, the chief faculty for the first session, and Dr. Sheila ma'am as a moderator also. A good frame for a screenshot, I was saying.
So meanwhile, is the screen visible?
Yes.
Yeah. Thank you.
Visible.
Education breeds confidence, and confidence breeds hope. Good morning. It's a pleasure to welcome you all back to the Day 2 session of 5th Annual OOO Conclave 2023. OOO is a conjoint facilitation of ASMIC, Association of Stomatologists and Immunologists of Kerala, KSOMP, Kerala Society of Oral and Maxillofacial Pathologists, and AOMSI, Association of Oral and Maxillofacial Surgeons of India. A new day embarks new opportunities. So let me not delay any further and start with our first session. I would like to welcome the speaker of our first session, Professor Dr. Ravikiran Ongale, sir, Head of the Department, Oral Medicine and Radiology, Manipal College of Dental Sciences, Mangalore, to present on the topic, Optical Spectroscopic Tool for Early Detection of Oral Precancers. Welcome, sir. I would also like to welcome Professor Dr. Ella Srilamal and Professor Dr. Ethan Thomas, sir, moderators for the session. Professor Dr. Ella Srila is a professor and head of the Department of Oral Medicine and Radiology, Government Dental College, Kottayam. Welcome, ma'am. Professor Dr. Ethan Thomas, head of the Department, Oral and Maxillofacial Surgery of Pushpagiri College of Dental Sciences. Welcome, sir.
Thank you.
I would like to request Professor Dr. Ella Srilama to introduce Dr. Ravikiran Ongale, sir, to the session. Srilama, could you please unmute?
Ma'am is having some network issues, I think. Dr. Sheila, ma'am, are you there?
Yes, sorry, sir, I hope I'm audible.
Yes, ma'am.
Thank you.
Professor Dr. Srilama, could you please introduce our speaker, Dr. Ravikiran Ongale, sir, to the session?
Sorry for the network problem. It's indeed a very happy occasion that I'm getting a chance to introduce radiology. I'm sure all the students here are very familiar with his name. So Dr. Ravikiran Ongale, he has earned his master's degree in the specialty of oral medicine and radiology from Manipal University in the year 2002. Ever since, he has been pursuing his passion for teaching. He was a recipient of the Good Teacher Award in 2012. He has authored 2 books in oral medicine and radiology and is on the advisory board for the first South Asian edition of the textbook of oral radiology edited by White and Farrow. He has been invited to speak at various CMEs and international conferences, and he was the symposium speaker at the International Association of Dental Research and American Association of Dental Research meeting at Boston in 2015 and keynote speaker at the Royal College of Surgeons in Ireland 2016. Apart from his interest in teaching, he is actually involved in funded international collaborative research projects dealing with prevention, detection, and medical management of oral precancers. He has filed 3 patents and has won various innovation awards. At the university, Dr. Ravi Kiran is a staff mentor for the Student Research Forum, member of the institution's Scientific and Ethics Committee, and also coordinator for the Innovation Center. He is the editor of the Chief Manipal Journal of Dental Sciences. Dr. Onkol is currently serving as professor and head and PhD guide at Manipal College of Dental Sciences, Mangalore. Welcome, sir. We welcome you to the session on optical spectroscopic tools for the early detection of oral precancers. I think the most apt person for the topic. Welcome, sir. How do you share screen?
Dr. Ravi, are you able to share your screen?
Somebody else is sharing the screen, I believe.
Only one participant is only actually permitted. You are not audible, sir. Dr. Ravi Kiran, you are not audible. I can see somebody's mobile screen is shared. Yeah. So you're not audible. Your audio is not actually, we can't hear you. Can you try without the headset and directly see? Is it working? If you just pull out the headphone jack and see if the audio is working.
So am I audible now?
Yeah, now you are audible, sir. Now you are audible. I think that there's something wrong with the device. What are you using? Are you using a Bluetooth headset or the wired headset? Can you share the screen now?
Am I audible now?
Now it's, yeah, now you are audible, sir. Now you are audible.
Thank you so much, sir. Thank you so much. So I just want to thank Srila ma'am for those very kind words of introduction. At the outset, I would also like to thank my colleague, Dr. Anuna, for giving me this opportunity to share my thoughts on oral precancers. Thank you so much, Anuna. I also like to thank the organizers of this 5th OOO Conclave. I'm very sorry if my voice is very babbled because just getting out of laryngitis. I shared my email at the end of this presentation. So if there's something really we need to discuss, we could probably send me a mail and I'll be really happy to discuss with all of you. So at the outset, I was when Anuna, I mean, first I should also congratulate the organizers for strictly following time. I'm so happy that it began at 9 o'clock. Very rare these days for, should I say, symposiums and conclaves and conferences to begin on time. And this is perfectly nice. I'll do my best to stick to the time allotted of 5 minutes. I'm sure I'll be done within that frame. So when Anuna called me saying if I could actually speak, I was telling her oral precancer is very close to my heart, and like ma'am just mentioned, I passed out of Manipal College in 2002 after MDS, and right from 2000, precancer and Dr. Kitlata Pai has been my teacher. She's really been a great influence in whatever I've learned. That's when I began to see the importance of history taking, the importance of conversing with the patient. I think that's the skill many of us lack. Many a times when I feel that I've not spent enough time with my patients, I think going back to those good old school days of trying to spend time with the patient is actually half diagnosis done. With that background, I was telling Anona that I've been working on oral precancer for almost decades now. And we all have a major role to play with regards to oral precancers. And what best forum can this be better than we have oral pathologists, oral surgeons, and oral medicine people on one platform? I think we can't ask for better. Let me share my experiences on early detection of oral precancers. In the season of, I should say, rapid reviews, I'm glad it's not a rapid review. So we don't need to really learn for exams now. We're just learning for learning's sake. Let's share our thoughts on early detection of precancers. I'll share my screen now. Hope the slides are visible.
Not yet, sir. Can you share the screen?
Again.
Are you able to share the screen?
Yes, I should be able to do it now. I'll do it again.
Yeah.
Now it should be visible.
Yeah, it's coming, sir. Yeah, now put in the slideshow, please. Yeah, perfect.
Great. So, yeah, perfect. Thank you so much. Now we can begin with our talk. I promised you to not take more than 30 minutes. Warm greetings to all of you from Manipal College of Dental Sciences and the university. This whole experience of learning, diagnosing wouldn't have been possible without the association, my association with a very important department called the Atomic and Molecular Physics, Mahe Manipal. Especially Dr. Unnikrishnan, Dr. Santosh Chidampal, and Dr. Karta was a very senior scientist. And over the years, I've been adding up people into our team, and I've also now associated with the Central Plantation Crops Research Institute, CPCRI. It's one of the institutes in Kasargod and one in Karnataka. Dr. Nagaraj and Dr. Hebbar helped me with it. And of course, without our own students, it's so difficult to make progress with any kind of research work. And these are two students, especially I'd like to thank them because they've been very passionate about studying oral precancers. Even Dr. Varsha now just joined in as a PhD student. As we progress, we'll discuss about their influence on the study. Though my topic is more to do with early detection using optical spectroscopic techniques, at the end of the slide, end of the presentation, I will share some good reads you can actually read if you're still looking at passing an exam. But otherwise, I think we should, as oral physicians, oral maxillofacial surgeons, and oral pathologists, should really understand what's the cancer burden. It's interesting since I keep saying, okay, over the last 2 decades is what I've experienced. So I'll share some wonderful data that will actually open our eyes, I guess. I like the statement which was found in the American Journal of Cancer that said, the full impact of cancer is impossible to quantify. I keenly listened to speakers yesterday. I spoke to, I listened to the oncologist, also listened to Dr. Gowda Patil. So we'll use their examples as we progress. Look at this amazing data by the WHO that projected in 2003, right after I finished my PG. That was published in British Medical Journal. I want all the pathologists and the surgeons to understand this too. They say currently 10 million new cancers are diagnosed each year worldwide. And with an effective preventive campaign, they say if you don't have a very good prevention campaign, the number would rise to 20 million in 17 years' time. So they're actually projecting for 2020. And they said the rates are set to double by 2020. These predictions are much better than the typical the award predictions that we have. Look at Globocan, that actually the part of the IARC. Their data in 2020, 19.3 million new cancer cases. So look at that whole data. They said 10 million and they said we could go to 20 million in 17 years' time, and absolutely wonderful prediction there. So what we're really seeing is there's absolutely no concerted effort. We all need to somewhere have a role, pitch in to have effective preventive campaigns. So now we're looking at a big number of 19.3 millions, okay? And as far as the Pan American Health Organization, which is part of the WHO, now they have a prediction. They say if we go this way, it'll increase by almost 60%. And by 2040, if you're all around, then probably we'll have another talk that time. They said the predicted global burden will increase to 30 million by 2040. And look at that last statement they make. They say the increase would happen in lower and middle income countries. So we have a major role to play with regards to managing precancers and especially diagnosing them early. In my previous talk, I remember a long time back, 2016 or so, I was in Pushpagiri College and also I also went to JDC with Dr. Srila. I remember as part of the Elsevier Auto Connect. I remember projecting the slide at that point of time.
So your audio is slightly getting weaker. Can you just hold a little more closer to your mouth? Yeah. Now it's gone for good. I think there is some issue with the headset probably. Now you're not at all audible, sir. Kindly just try once again the earpiece.
So I'm audible now?
That is, yeah, perfect. Perfectly
Okay,
audible.
I'm so sorry about this. So if you look at that 2013 data, and we always talk about we don't have data from the Indian government. Actually, I should let all of you know that there's this website called the National Institute of Health and Family Welfare, Government of India. All that you need to do is put that NIHFW GOI in Google and you have daily bulletins there. In 2013, the Government of India said 2,000 people die every single day due to tobacco-related diseases. And one statement up, if you go up, it says chewing tobacco and gutkha contribute to 90% of the oral cancer cases. Look at what the NIHFW says about in 2023. This is from India. 2.5 million cancer patients at any given point of time. And about 0.7 million new cases coming every single year. And half of these die every year. Second statement also is very interesting. They all know, they all telling it very proudly that a third of the new cancers are present at advanced incurable stage. And look at that, we proudly mentioned that in the Indian democratic context, we all have young individuals who are healthy and able to work, but % of these people who die are all affected by cancer are between the ages of 35 to 65. All the productive years are gone managing cancers. That's a data from the Indian context. Let's continue looking at India 2023. Very interesting. I want to bring this point across to every single person here. It's really not the problem of the community dentist or the medicine person. 80 to 85% of tobacco is consumed in BD as form of BDs or cigarettes. Most common form is BD, which is 34%. Look at that packet down below. And if many of you are aware, in 2015, they had this worldwide program where all the countries signed up and said, we will display that tobacco is injurious to health. And many of you must have seen cigarette packets, right? With almost 67% marking injurious to health. Just look at that. One simple example of a BD packet there. And I hardly see anything mentioned as saying injurious to health. Many of them in India chew betel quid. I'm not sure how you can label the betel quid there, really saying it's injurious to health. We have bigger issues to tackle with. It's really not just putting one picture of injurious to health on a cigarette packet. And that statistics change. Look, remember when I told you 2013, let's go back there. Remember I said it's 2013 saying 2,000 people die every single day. Let's look at India 2023. In India, more than 2,000 people die every single day. So that hasn't really changed. We have a major role somehow to play in regards to diagnosing precancers. Cancer is
Excuse me, sir. You're not audible now.
Yes, ma'am.
okay now.
Um,
Audible now?
yeah, yes, sir. Please.
Okay, yeah. Thank you so much. Keep letting me know if I'm not audible. Okay.
Sure, sir.
So cancer cases in the country are set to go to 13.9 lakhs and likely to increase to 15.7 lakhs 2025 in just 2 years. So let's look at this last statement and then I'll move forward. The reported cancer incidence in India is estimated to be 19 to 20 lakh. That's the reported incidence. That's all from the cancer registries. But everybody even says that this is just what is reported. It will almost be 3 times higher. So that's 1/3 of my presentation. The whole idea here is to just come and relate to every single person today that there's a big challenge every single day. They're looking at numbers that are equal almost like 80 people die every hour. So by the time we finish this lecture, 80 people have died because of cancer. Very interesting statement by the AJCC, which said the only way to avoid cancer is not to be born. So invariably, we kind of understand that yeah, someday somebody would have cancer. Then there should be a role. What we all can do as OOO specialists. What can we do? The way I look at it is 3 basic prongs to this problem. One is prevention, the other is early diagnosis and management. Management, of course, it's like a breakthrough, right? I mean, there's nothing much you can do. Whatever's there, you need to treat them. Like the surgical oncologist mentioned yesterday. Early diagnosis, we need to find some very innovative tools. It has to be something very innovative. It can't be the typical biopsies every time. It cannot be use of well scope. It has to be something where we can catch cancers very early. There's no fun in seeing a pre-cancer already existing in the mouth and say, hey, yeah, it's leukoplakia, now let's biopsy. Can we actually do something more ahead of all that? And of course, prevention. Prevention is something I think we all should really put in lots more effort. I would like to slightly disagree with I actually would start with congratulating the oncologist who spoke yesterday, saying he even put up this oral examination slide. I'm very happy he put that up. But he said, yeah, it's all there, but you don't need to systematically examine. I would say, yes, you have. There is no second round. There is no second. You have to systematically examine the oral cavity. There's no shortcuts. Every single part of the oral cavity, and it has to be like a routine. We all know of the very popular breast self-examination for women over 40 years of age. I think inculcate, if you even talk to undergraduate or postgraduate students today, first statement they make when it comes to precancers or cancers, habit counseling. They all talk about it's bad, discontinue, and everything else that we speak to. But we need to also inculcate this habit of telling the patient do a good oral self-exam. Yes, today he doesn't have a precancer, but he has a habit history. You should ask the patient to stand in front of a mirror. It's just this oral exam is just not for the dentist, not for the oral physician, not for the pathologist, not for the maxillofacial surgeon, but it's also for the patient who knows he's chewing. He needs to pull up his lips. He needs to check his mucosa. He needs to check his tongue and come and let us know if there's anything abnormal there. Okay, so oral self-exam is what we all need. Please let PGs, please let UGs know. Every single student here attending today should make it a point to do a good oral examination. I mean, I can make fun of conservative dentists and here because we don't have conservative dentists, hopefully. I always tell my students for teeth replacement, for fillings, there's somebody else. For scaling, there's somebody else. Don't worry about them. But an oral exam is what you need to do. I honestly don't even care too much if these people miss out a few carious lesions. I always tell my students, I will not forgive you if you miss out a soft tissue lesion. That's exactly what we need to look out for. Okay, let's move on. So we need to now see how we can diagnose cancers. We all know that oral precancers are generally, I should say, generally preceded by some kind of a precancer, some kind of an oral change. And these malignant transformation rates, I mean, though they are not really sacrosanct numbers, so I'm saying 44, 17, it actually varies. It varies from region, it varies from habit. It also depends on how people have followed up after how many years. So let's not go by too much of these numbers. Just for us to know that, yeah, majority of them can turn into oral cancers. That's the importance of the slide here. This we all know, but I need to, let's look at this one more time. Delay in diagnosis or patients reporting an advanced stage of disease. That's the biggest challenge. Every single paper that you come across keeps talking about this. Somehow all of them who come to tertiary care centers are always at that advanced stage of disease when you can't do much. Now, what's our gold standard? A gold standard is a biopsy. We always know that the only way to assess dysplasia is to go for a biopsy. Somewhere along the line, at least if Dr. Srila ma'am or anybody who's senior sitting here, we've all been taught to use vital staining. For some reason, for a couple of decades, I have not seen many use toluene blue at all. It's like a 10, 12 rupees bottle. So you simply have to apply on the mucosa. At least it will tell you the most representative site for biopsy. I should just put in a point here. I remember the surgical oncologist speak about you should take a good biopsy specimen. It should be deep enough. I mean, I'm really not ashamed to say that I don't encourage my postgraduates to say, let's do a biopsy. Yeah, I know it is part of the DCI curriculum. It's nice to know. It is, as dental surgeons, we are allowed to take a biopsy. And what's there is just a scalpel, a small cut, then suture, one couple of holding sutures. Sometimes even don't suture, it'll heal. But the point is not the technique for biopsy. It is not about learning biopsy. It's not about meeting regulatory requirements. But the point here is this tissue specimen that you take should be diagnostic. I have absolutely no shame in letting you know that all my cases for biopsy always trust a maxillofacial surgeon to do my biopsies. So many oral medicine people who disagree with me saying, hey, even we can do it. Yes, we can. I've done almost every biopsy, but I still believe it's a job. But if it's a neuralgia and I need to medically manage, I won't let anybody else touch my case. I mean, I have a maxillofacial surgeon wife at home. So when we discuss about biopsies, I actually, it's very interesting to know. I just have the files from oral pathology. Somehow, maybe I might bad at biopsies, but we find those enough with specimens for biopsy coming out from many of the non-clinical. there is most often than not the surgeon is confident of
Excuse me, sir. Your audio is getting weaker.
Okay, is that better?
Yes, yes.
Yeah, thank you, Mika. So, like I was just mentioning, so I have absolutely no qualms about sending out my patients to a surgeon for a biopsy but then when I send them out for a biopsy, I'm actually sitting on their heads because I dictate to them where the biopsy needs to be taken from. Whether you like it or not, many find it offensive, but I say, no, this is where I need it from. And how do I know? Not my expertise, but I greatly rely on toluidine blue. I still believe toluidine blue is the best way to identify the most representative site for biopsy. It is not going to tell you it's precancer. It's not going to tell you it's cancer, but it will tell me and the surgeon and everybody else that this is the site I need a biopsy from. And when you do it, 100% sure that you never made a mistake. So why take the chance of multiple site biopsies? God only knows where you missed a lesion. So I think we should just leave this to the surgeons to do their job of biopsy, leave it to me to tell them where to do the biopsy from. So we should go back to that school of vital staining. Yeah, and that's perfect. I'm extremely pleased with every single toluidine blue staining and then Lugals to tell me the margins. And then I'm really happy saying, hey, this is where I take my biopsy specimen from. Over the years, I mean, I'm just looking at some gold standard and some advances, and then the last 10 minutes of my lecture, we'll go to optical spectroscopy tools. Over the years, we also have heard a lot about Wellscope. There are people who ask, should we use it? Some people say, yes, you should. Western literature shows great use of Wellscope with regards to specificity and sensitivity. To me, it's a very costly 5 lakh toluidine blue because I'm not seeing major advantage. I mean, I've used a good friend of mine is Dr. Praveen, who's in KD, Bangalore. He does a lot of work on cancers. He also has a tool developed for detection of cancers using tissue autofluorescence. But then my question to him most of the times is, yes, it's good. KSA Wellscope is nice. It's telling you where to do the biopsy from. But then that's what toluidine blue does. Why spend 5 lakhs to show you where to take the biopsy specimen from? Also, the other challenge I find both with toluidine blue and Wellscope is you need to have an morphologically altered tissue already. It means every single buccal mucosa that look normal, I can't keep staining because the vital stain is not going to take up anyways. Nor is Wellscope going to show you. Where would you point your the Wellscope, the probe onto? Which part of the mucosa? I understand if it's already looking morphologically bad. If it's leukoplakia, yes, I know where to place it. If it's rosiform like in penis, I know where to place it. But what if the mucosa looks normal? So think of a situation where you have a 60, 70-year-old BD smoker and the mucosa looks okay, except for some melanosis. Where exactly is it going to help you? So that's my whole big problem with using Wellscope. So yeah, these are gold standards and absolutely no faulting them. We still have to rely on gold standards. This is the big problem. Even a biopsy, where would you do it from? From already a morphologically altered tissue, right? You can't take a biopsy specimen from a normal looking mucosa. It's not ethically all right. And where would you take the biopsy specimen from? That's the biggest drawback, even with the gold standard. And if it's already morphologically altered, that's exactly what we've been talking the last 20 minutes, where we said majority of the patients who report at stage 3 and 4 already changes occurred. There's nothing much you can do. Right? So we need tools. We need to experiment. We need to be taking those risks to develop tools ourselves, which will tell us, hey, there's something wrong. It's like the treadmill test the cardiologist would ask you to take when you're 45 and say, look here, take it easy, yoga, meditate, breathing exercise, and God knows what. So we'll have to get to that stage where we are telling our patients, hey, look here, I know you're smoking, I know you're chewing, I know today there's no change in the mucosa, but I have a tool that can tell you, morphologically, though nothing's seen, biochemical processes inside the mucosa are already going wrong. Over time, if this continues, you'll end up having a morphologically altered tissue. And to answer that question, we will have to look at optical spectroscopic tools. It's 9:35. I'll take 10 more minutes. So my association with, this is my experience of the last 2 decades. I'll share them with you. We haven't, except for about 3-4 papers, we haven't publicized this much because it's every single day, it's still an experiment. We are still learning. Hopefully it will see the test of time someday. So when you look at these optical diagnostic tools, this is the biggest advantage. You can diagnose even before any morphological alteration of tissue is seen. It's non-invasive, it's real time, and we found very highly accurate results. A couple of these slides I did share in a couple of conferences, but I'll add new data now. So the journey is over 3 basic optical tools. We began initially with something called a HPLC LIF, which is high performance liquid chromatography with laser induced fluorescence. The next generation is we knocked out HPLC and just used laser induced fluorescence. And in the last 2 years or so, we've been using another technique called LIBS, called laser induced breakdown spectroscopy. So basically 3 generations, 3 different lasers, different uses. The first one that I'm talking to you about is protein profiling. And it's in vitro. This is not an in vivo instrument. This is in vitro. It needs a lab setup. But let's look at how advantageous this can be. So this is currently, though I say it's a lab setup, it's not like a huge lab space it'll take up. It can be fitted on a surgical trolley. What this has, if you look at this picture here, essentially is argon laser. It's 257 nanometer argon laser. HPLC is a high performance liquid chromatography, has been used over many decades, especially in the pharmaceutical industry and pharmacological labs, where the basic function of HPLC is to break down the products. I mean, any product you put into this HPLC, the sample that you put into would break down into its constituents products. So in this case, our experiment, what we did was we started off with saliva, and we also took serum. I call it non-invasive, so let's stick to saliva and serum both. So say I drop in a specimen about 5 ml of, say, a saliva sample. The HPLC will break it down into its a chain of protein molecules. And you understand, multiple protein molecules. These protein molecules would be dropped through a quartz capillary, so a thin, fine capillary tube. And you can actually imagine one ball of imagine one, like a bubble, each protein molecule traveling down through that thin quartz capillary tube. We'll only allow one at a time. As this chain of protein molecules are coming down, this argon laser will strike the protein molecules, and these proteins fluoresce. The proteins that fluoresce are called fluorophores. Each fluorescence that is produced every single time the laser strikes the protein, there's fluorescence that is captured. And I can show you some images now. And that is shown real time on the monitor. So we run the sample for about 30 seconds. End of 30 seconds, what you get is a spectral signature like this. It's like those ECG graphs that you get. Now, what's very interesting? If you look at the first picture here on top, it's called chromatograms of the normal saliva samples. I took a male and female sample. It's so interesting to note for this whole 30 seconds. Can you see this time down below? This whole 30 seconds, you'll be surprised to see, for example, say 400 and what's this, about 500 seconds. Exactly the same protein molecule coming out. Something, God alone knows which protein is that. Today we don't know. We are still comparing with protein libraries, but exactly the same profile in all the normal samples. Exactly the same protein profile in normal males and females. Exactly the same. So there is some protein that is eluting at that particular point of time. Exactly the same peaks. These are called spectral signatures. So these will not change. it's like a signature. It's like my signature. So I say for normal samples, this is how the spectra will look like. Okay, then we looked at smokers' saliva samples. If you look at smokers, you suddenly see all these peaks have vanished somewhere. They all have different alterations, right? So it means some proteins are getting very exaggerated in them and some are totally dropped off. There's some new protein peaks coming in. And then look at these precancers. It's, I mean, even probably a partially blind person, you don't need a clinician to sit there. He'll tell you this first is, he'll at least tell you something wrong. It is not this leukoplakia lichen planus worsen. It's for now for us to find out what each one of these protein molecules are, but we straight away say it's not normal at all. So when I see now, we look at this extreme, we look at normal, we look at precancers, but let's look at saliva smokers. I'm already telling a smoker, hey, you are smoking 3 to 4 cigarettes a day. Something wrong with your sample already. It's likely that over time you'll end up going here. So this is an amazing tool, and this was published earlier and later in Current Science right after experiment. But it's telling us there's something wrong with the sample already, which I'm pretty confident none of the other techniques would tell you there's something wrong so early. These are serum studies. These are healthy volunteers, somebody with smoking, the protein profile changes, the peaks. If you notice, there's a tiny peak here that's gone, totally missing here in a smoking person who smoked, and new peaks seem to develop in people with alcohol too. So this is from serum. Healthy volunteer, malignancy and malignancy. You'll see new peaks developing. You'll see these peaks vanishing. You'll see another third tiny peak. So we started numbering these peaks because today we don't know what that molecule is. And we gave a kind of classification that tells you it's either precancer or cancer. Okay, so just to collate all of them, we put all the 3 samples together. Let's go right up to the end of time, about 1350 seconds. You see this high, nice intensity of this protein in normal patients. See what's happened to it in malignancy. It's fallen down below. This is good enough to say this sample is malignant. And all these were matched with biopsies. Okay, so that's what happened. The second generation, we now started using, got rid of the HPLC, and now we use only a probe. The probe we are currently working on, if you look at the probe, is very straight now. We are currently working on a probe that can be contra-angled. Let's look at how this would look. Yes, like I told you, just a surgical trolley. All the examiner has to do is place this against the buccal mucosa, and you'll literally see real time. You see these spectral signatures from various parts of the oral cavity. Just to give you a little more details, since even yesterday we are talking about biopsy specimens need to be deep, have to go to the connective tissue. If you look at the epithelium, you're looking at NADH, and at the connective tissue, you're looking at collagen. It's normal spectrum. So peak number 1 that you see here, that's with our laser line, that with the probe that I was talking about. Again, this is a paper that was published in photoelectrochemistry and photobiology. You look at this peak that is NADH, and this is the peak for collagen. That's normal spectrum. Please remember these 2 peaks. Let's see what happens in malignancy. You see a total loss, right? It's totally gone. So this is absolutely, it's as simple as, and now if you can start to categorize this, then we can start to match with our TNM stage again. So, I mean, there's a lot of work still to be done, but these are very initial encouraging results that we have with the laser probe. So that was, I have 2 minutes of my story and I'll be done. So over time, I realized that, okay, so that's one part of the spectrum. We are actually looking at morphologically altered tissues, slightly lesser than morphologically altered, somebody who's smoking, chewing, but no change. But then other part of the problem is the habits that people have, right? They chew gutka. I just mentioned people smoke BDs, people chew gutka, people chew pan. I am currently working more to do with areca nut and pan and betel leaf. I'm not too concerned about BT. I'm looking at non-smoking kind of the last 10 years or so. Recently, we started using a new tool, and what we did here was to assess trace elements in commercially packaged forms of tobacco and regular, I mean, these packets. I'm a little worried that with publishing these results, the people making gutka and pan will be behind us. But if you actually look at, if you go to a pan shop today, many of the states, gutka is banned. So they give you a pan masala as separate, which clearly mentions no tobacco. And they sell tobacco separately. We used a technique called laser-induced breakdown spectroscopy. That's another laser. What this laser does is any sample you place, let me look at this. Yeah. So we ultimately took gutka, powdered it, make small pellets out of them. And you place a small pellet there and strike a laser. The laser is so powerful that it causes plasma. It actually takes away part of the specimen, a small tiny micro hole there. And that specimen is analyzed for, it gives you like mass spec, it gives you all the elements that are there, just throw up all the elements that are available. What is shocking to see is that the elements that we found, and of course we use the National Institute of Science and Technology, there's a database that tells you all the element spectra. We literally mapped all the elements. You see aluminum, nickel, chromium, calcium, which just shows you that this sample have all these elements. The reason why I'm doing this is the whole concept that we learn in school about copper as one of the major constituents of areca nut and the lysyl oxidase pathway. We all know that it causes fibrosis. Initial results are very shocking to let you know that areca nut did not have copper. Okay, so we'll have to see more about it. But now what am I trying to say here is the packets of pan masala. Okay, these are the pan masala and tobacco. PM is pan masala and T is tobacco. Surprisingly, the elements are the same. Whether it was a typical pan masala, which are very clearly saying no tobacco, plus the ones with tobacco have exactly the same elements. Even more worrying is both of these have nickel and chromium, which are carcinogens. Okay, so anyway, that's I just took a few points out from our current PhD study. So that's all I was just trying to explain. So if you had to look at the current optical tools and what we discussed, shared the thoughts in the last 40 odd minutes was we have to, all of us, the triple O's, need to seriously think of the disease burden. Those predictions are absolutely bang on target. They're only going to multiply. We know there are gold standards, but we need to explore and experiment with new tools. It's for us to diagnose early. And please remember, oral self-exam, very important, apart from these spectroscopic tools, which may not be readily available for everybody, but I would still suggest stick to toluene blue, do a good oral exam. Teach patients to do good oral examination. People in medicine, people in pathology, people in surgery, I would suggest, please read up. These are good articles published in Biomedical Optics. There's a journal called Lasers in Surgery and Medicine, Optic and Spectroscopy. It's just not for physicians, not for physicists, but it's also for us. To leave you all, I'd say change will not come if we wait for some other person or if we wait for some other time. We are the ones we've been waiting for. We are the change that we see. Unquote, and that's from Barack Obama. Thank you all so much. I was telling Anuna, I wish I was there personally to interact with all of you. I kept asking her multiple times, hey, am I going to come there? She said, no, you're not coming. It's only online. I wish someday I could just come back and speak my mind out with all of you. My email is right there, oralmedicine@gmail. So you have something to discuss. Let's do it on me. Thank you all so much. Thank you, Anuna, for the opportunity. I thank the moderators. Thank you all so much.
Thank you so much, Ravi Kiran, sir. Sir has taken a lot of effort to present this paper, and in fact, sir was not keeping well. Sir was having severe laryngitis. According to sir, sir has not been speaking to anybody since yesterday, and he was serving all the voice, the sound for us, especially for this talk. Thank you so much, sir, for all the effort that you have taken to make this presentation. Now the time is open for discussion.
Over to you, Professor Dr. Ellis Srilana.
Thank you, Dr. Ravi. That was very enlightening.
Thank you.
As Dr. Anuna was saying,
Ma'am, could you please unmute yourself?
Am I audible?
Yeah, ma'am. Yes, ma'am.
Okay, thank you. So I don't think there are any questions in the chat box. Maybe we should pursue. All of you have found it very interesting, but yes, now I find there's a question. Can we differentiate between various OPMDs? That is a question, sir.
Am I audible?
Yes, sir.
Yeah, yes, absolutely. You can. I mean, we do definitely find a lot of difference between each of the OPMDs. We also find a lot of variations in the severity. If you have to check with, we did a couple of cases where we did a biopsy, checked the dysplasia, and actually could match with the dysplasia also in each of the varieties. So it's going to take us some more time to very confidently say yes, but yes, surely yes, there's definitely a difference between the optical signatures of all the OPMDs.
Thank you, sir. Any more questions coming up?
So you're not
Do you
audible.
have any experience with the scan?
Yeah, absolutely none. I even don't know what that means.
That is visible lights. Are they using visible light?
Ah, okay. Yeah, so yeah, good question there. Okay. So, okay, so that was exactly what I was speaking to you about well scope earlier. So if you have to look at the differences, I mean, to break it down to very layman terms, in well scope or the scope that you spoke about, they use LEDs, so it's just visible light. The big problem with LEDs is it's not monochromatic. So it means there'll be multiple colors of light and it diverges. So the advantage with lasers, it's monochromatic and it's coherent. So you don't get divergence, a single beam. So the amount of information that you get and the depth of penetration you get to tissues is much more better with lasers.
Thank you, sir. So can you comment about the expense involved? What
Yes,
about the expenditure side?
yes. So again, good question, ma'am. Thank you so much. So currently the setup, what we did was we took a grant from DST. My colleagues in the Atomic and Molecular Physics had a grant for 1.2 crores by the Department of Science and Technology. The biggest expenditure is that laser that costs almost like 60 lakh rupees or 70 lakh rupees. However, two labs are currently working, including the lab that we have in Manipal, working on Indianizing our own lasers. Once we do that, it should fall to close to almost like, I should say, 12-15 lakhs. And that's a single equipment. So once you mass produce like well scope, it should definitely be much cheaper, is what we. But we're very far away from that to mass produce and all that, but it's more like an experiment today.
Thank you, sir. Any more questions? So let us hope a day will come when we can stop with the invasive gold standard biopsy and go for very easy detection of early detection of pre-cancers, which may prevent the progression into oral cancer. Isn't it, sir?
Yes, ma'am, absolutely. Sir, I see one question from Babu Matthew sir.
Yes, can you use this?
Yes. Sure. So absolutely, sir. Yes. So, sir, actually, like I was mentioning, over the last 2 decades, we moved the surgical trolley to multiple cancer screening locations. We let the people know it was an experiment. It was research. Most of the samples that we've collected have been off-site. It's not in a tertiary care center. The samples that we collected, fluorescence spectra, was on the site. So definitely, yes, it can be used for mass screening. But again, mass screening, today we can see only one side, but over time, if we have multiple equipment, yes, again, the cost factor would come in, but yes, it's definitely a mass screening tool because it's real time.
And anything like limitation with the numbers, like you can do only so much cases.
No, ma'am, there's absolutely not. It's just the turn time, I should say. That is, there's a sleeve that we use, a plastic sleeve that needs to be over the laser probe, that needs to be autoclaved. If you have these multiple processes, I see less than about 3 minutes between every patient. 3-4 minutes is what we take.
So thank you again. Any biosafety issues with laser?
So the lasers we are currently using have been approved by FDA for intraoral use, so there's no safety issues.
I think we can actually wind up this first lecture. Thank you, Dr. Ravi, for giving us that descriptive lecture and those glaring facts about the statistics about oncology and the cancer spread and the propensity in the upcoming years. Thank you so much. That was a wonderful presentation. Over to Mika. Are we giving the certificates now, Mika? How is it going to be?
Yes, sir, we'll be presenting the certificates. Thank you, Dr. Ravi Kiran, sir, for such an informative session. And I would like to extend my appreciation to Professor Dr. Srila Ma'am and Professor Dr. Ethan Thomas, sir, for moderating the sessions. Kindly accept our token of appreciation now.
Thank you.
First, I invite Professor Dr. Ravi Kiran Ongole, sir, to accept the token of appreciation.
Thank you so much.
Now I invite Dr. Ethan Thomas, sir, to accept our token of appreciation.
Thank you.
Now I invite Dr. Ella Srilama to accept a token of appreciation.
Thank you very much.
Thank you, ma'am. Next, I would like to welcome the speaker for the second session, Professor Dr. Bobby John, sir, Department of Oral and Maxillofacial Surgery, Government Dental College, Kottayam, present on the topic odontogenic cysts and tumors, current perspective. And I would also like to welcome Professor Dr. Ethan Thomas, sir, and Professor Dr. Anuna Leila Matthew, ma'am, our moderators for the session. Professor Dr. Ethan Thomas, Head of the Department, Oral and Maxillofacial Surgery, Pushpagiri College of Dental Sciences. Once again, welcome to you, sir.
Thank you.
Professor Dr. Anuna Leila Ma'am, Head of the Department, Oral Medicine and Radiology, Pushpagiri College of Dental Sciences. Welcome, ma'am. Now, I would like to request Professor Dr. Ethan Thomas, sir, to introduce the speaker, Professor Dr. Bobby John, sir, to the session.
Thank you. Thank you, Dr. Mika. And I would like to welcome the second faculty for today's session. The second faculty. This is none other than our own dear Dr. Bobby John. He is an additional professor in the Government Dental College, Trivandrum. He is actually one of our renowned speakers who actually speaks extensively in the national and the state conferences. He has a lot of accolades to his credit. He is one of the persons who's actually specially trained in TMJ procedures and TMJ arthroscopy. He has an international certificate of oral and maxillofacial surgery, fellowship in international certificate of oral and maxillofacial surgery, as well as FIBOMS. He is also a member of the Royal College of Surgeons. The list goes on. And he is one of the persons who actually, whenever we give a topic, he actually extensively researches into it and always surprises us with some new findings and some new revealing facts with his presentations. And I'm sure we all are lucky to have you, Dr. Bobby, here. Over to you for your presentations, sir. And the topic, what you're going to present would be about odontogenic cysts and tumors, the current perspectives. Yeah, can you put on slideshow, Bobby? Yeah.
Ethan, is it visible?
Yeah, your screen is visible, doctor.
Okay. So shall I start?
Please.
Respected moderators, senior faculty members, and my dear friends, a warm good morning to you all. At the outset, let me thank the organizers of this OOO conference for giving me this great opportunity. And I should not fail to mention the name of my good friend, Dr. Epen, for personally inviting to be a part of this conclave. And the topic assigned to me is odontogenic tumors and cysts, its current perspectiveness. So it's a very extensive topic, an elaborate one. So I thought that I will pick a representative from each category, one from tumor and one from cyst, so that I can do justice to the allocation process to me. So we can describe in detail about each one in each category. So from time immemorial, we are so familiar with this classic definition that was proposed by Robinson. So we study it from the third year undergraduation level, which describes the 5 features of ameloblastoma. But once you search the literature, you see that it has some aggressive growth pattern, undergoing metastasis, and also some malignant transformation. And even some literature even try to compare it as a counterpart of BCC, basal cell carcinoma. So we think that this classic definition is inadequate or insufficient. So Scuba came with a definition in 2005 saying that it's an aggressive odontogenic tumor that is formed from odontogenic epithelium but devoid of ectomesenchyme. But 2017 witnessed a dramatic difference in giving a new definition by WHO. So it categorically states that it's a benign progressive lesion, intraosseous, and it is an epithelial neoplasm also. But there are 2 features. One, it is of expansile nature, and 2, the tendency for recurrence. So it is intraosseous, it is a benign, it's an odontogenic epithelium of a neoplasm, but having 2 salient features of expansion and local recurrence. So why we are so concerned about this ameloblastoma? It accounts for about 14% of all jaw tumors. And it is the most prevalent, especially in developing countries. When you search the literature, especially from countries in Africa and especially in Asia, especially China, you get it's the most encountered odontogenic tumor. So what are the reasons? It can be attributed by various features like related to trauma, inflammation, nutritional deficiency, caries, or extraction. So numerous etiological factors can be attributed, and when we trace the lineage, we can see that it accounts from the cell rest of Ceres or molasses, or even of the lining from the cyst that has been existing there, or the basal cells. And very rarely it also develops from the heterotropic epithelium. So when you the lineage of the cells belongs to the cell rest as well as the lining of the cyst or the basal cells. So there should happen something in the developmental process. Either the pre-ameloblast to ameloblast differentiation getting blocked, or there is a stratum intermedium get absent, or breakdown of the stellate reticulum. So if anything happens in this developmental process, there's a chance of the neoplasm to develop. But now it is mainly the genetics or epigenetics that comes into role. So just remember that it is the MAPK pathway that is the most important thing. It is actually a pathway that is related to cell proliferation. And one of the common genes in MAPK pathway is the BRAF gene. But unfortunately, this BRAF gene will undergo a mutation. And this, when it undergoes a mutation, naturally, it results in an enhanced cell proliferation, enhanced survival, and ultimately a neoplastic transformation. So this is what happens in the ameloblastoma. There is a mutation of BRAF gene in the MAPK pathway. Then along with BRAF genes, you can have some other genes also. For example, RAS gene, RAS gene, and also fibroblast growth factor receptor, FGFR2 gene. So remember, there are 3 genes that are most important in the MAPK pathway. That is the BRAF gene, which commonly get mutated, then followed by RAS mutations, which accounts for 20%, and the FGFR mutation. So this is the pictorial representation which gives you an idea that we have the BRAF gene mutation, we have the RAS gene mutation, that RAS can be of different types, and FGFR accounting for 10%. So when these mutations occurs, what happened is that the MAPK pathway becomes very active. So there is a cell proliferation in an uncontrolled fashion, and these cells survive all the conditions, and a neoplasia is sets in. But remember, not only the MAPK pathway, some other pathways can also attribute to the development. And here you come to the familiar SHH, that is sonic hedgehog pathway. So this is the sonic hedgehog pathway. Just remember, there is a gene called the patch gene, that is a counterpart of the human counterpart of the Drosophila. So it is having a ligand with the SHH. So when patch gene is in a ligand state, it always have a control on the SMO, that is a smoothened gene. But when a mutation of the patch gene occurs, the SMO is freed, or SMO becomes independent. So the SMO began to become active. It activates gly proteins. Again, the transcription process sets in. So once the patch gene undergoes a mutation, it loses the control over the SMO. SMO becomes active, and the gly proteins active, and altogether again the proliferation of the cells occurs. So for the postgraduates, I would always say that remember two pathways like sonic hedgehog pathway and MAPK pathway, which are responsible for the development of neoplasia. So in 2005, WHO gave this classification based on location and histopathology, where the most common one is the solid or the multicystic, then followed by unicystic, extraosseous, and desmoplastic. But once you reach in the new classification, the blue book by WHO, these are the 5 categories. We have the conventional, the unicystic, peripheral extraosseous, metastatic, and the 5th variant, that is a new entrant, that is adenoid ameloblastoma. So in the 2022 meeting, the 5th variant is adenoid ameloblastoma. Why adenoid ameloblastoma? We call it as because it has the characteristics of ameloblastoma-like component and the presence of duct-like structures. So both this makes it the coin the term adenoid ameloblastoma. But we are very careful about this. The reason is that it is highly aggressive with higher recurrent rate. But you can't see the BRAF mutation in the case of adenoid ameloblastoma. And 2016, this term has been removed as a separate variety. It is still considered as a histological variant, that is a desmoplastic ameloblastoma. So what is the clinical picture? It's almost same. That is, it starts with the innocuous intraoral swelling. Most of the time, the patient may be unaware, and they become aware when it expands to such a large size to give a grotesque appearance. So there is a buccolingual expansion can be seen. The bone initially may be firm. Then, depending on the degree of resorption, it becomes paper thin, eggshell crackling, and finally the complete bone getting resorbed, you get a fluctuancy since it is just beneath the mucosa, and some other features like the neurosensory disturbances, the mobility of the segment of the teeth, and when getting infected, pain can also be a symptom. So the clinical picture almost remains same. So initially, radiography was the gold standard years back, and it was a good starting point also. But you can't demonstrate a 3-dimensional picture due to the expansile nature of the ameloblastoma. So the conventional CT or CECT became the gold standard. Do we need an MRI? Especially when you want to delineate the extensions of the maxillary ameloblastoma. We know that in the maxilla, it becomes very dangerous. It expands in a very speedy manner and encroaches the adjacent spaces like sinus, orbit, or skull base. So we need to have the soft tissue details. Definitely you need a MRI, especially in maxillary ameloblastomas. Do we need a PET scan? Especially when you suspect distant metastasis or diagnosing malignant ameloblastoma, PET becomes a favorable tool of investigation. So, but still now we have the greatest accessibility to CBCT. So it becomes the gold standard or the favorite choice of radiological imaging, and MRI to look for the soft tissue component. So here we can see that the resorption It can be a multilocular or a unilocular, whatever may be, but there is a resorption of the bone. So naturally the question is, why this resorption occurs? This is the picture that explains it. We know that osteoclast is responsible for the resorption, but many a times the osteoclast remain as inactive state, or we call as the pre-osteoclast. This is because it has a receptor called a rank, and the wrangle that has been secreted by the osteoblast is attached to it and it remains there. But once the wrangle get attached to the rank receptor, the pre-osteoclast get converted to osteoclast. Now the osteoclast began to eat the bone, and thereby you get a bone resorption. But in a normal anatomy, the osteoclast will make resorption, but at the same time, again, osteoclast will be under pressure from the OPG, that is the osteoprotogerate, again secreted by the osteoblast, so that further osteoclast differentiation does not occur. So remember that if the rank receptors getting liganded, the pre-osteoclast easily get converted to osteoclast. There starts the resorption process, but there is always a checking process by the OPG. But when the benign neoplasm sets in, the osteoclast becomes unquestionable. There starts resorption in a very unidentified manner. So this causes the resorption in the bone. Do we have a staging? Yes. If the tumor size is less than 6, we stage it to the stage 1. If it is more than 6, stage 2. And finally, if it inverts the skull base or there is a metastatic lesion, you can call it as a stage 3 as proposed by Young. Biopsy, definitely it is the gold standard to get a diagnosis, especially from the histopathological analysis. So we come across these things, the basic 5 types of histopathologically, and the 2017 variant, that is the desmoplastic. So now the question comes, why there is a squamous metaplasia, especially in the case of acanthomatous? Its nature, the reason is the presence of the stellate reticulum that is derived from the ectoderm, and it has the ability to form keratin. And there may be 2 important components of the keratinization, that is the keratohyalin granules and the tonofilaments. So that attributes to the squamous metaplasia. Then in the granular cell, why these granules appears? They are cuboidal or columnar cells with eosinophilic granules, with acidophilic nature and lysosomal aggregates. So what are the reasons for this? The granular changes can be occur due to the lysosomal insufficiency, or it is maybe a part of the degenerative or aging process. So we are all familiar with these histopathological criteria, Vickers and Gorlin. That is especially it can be used for the unicystic cases where you see the cuboidal or columnar basal cells with hyperchromatic nuclei, nuclear palisading with polarization, cytoplasmic vacuolization, and intercellular spacing. These are the 4 criteria that has to be met to get a diagnosis according to Vickers and Gorlin. But now literature see that some rare variants can call as the amyloblastoma, papilliferous amyloblastoma, or keratoamyloblastoma. But WHO has not given true recognition because of the reported cases are very fewer in number. So that amyloblastoma that metastasis, despite its benign histological appearance, you call it as a metastasis in amyloblastoma. And how do this get a metastasis? It can be through the bloodstream, it can be through the lymphatic stream, or through the aspiration process. So it moves into a distant place. And amyloblastoma carcinoma is a malignant counterpart. It's a rare primary epithelial odontogenic neoplasm with a lot of synonyms in the literature. So coming to the treatment options, just remember that we can have a surgical or a non-surgical. And surgical again can be radical or conservative. So in the non-surgical, it can be radiotherapy or chemotherapy. So in the surgical, we can go for a conservative approach or go for a radical approach. In the conservative approach, it can be mainly starts with the marsupialization. If it's a very extensive one, we can go for a marsupialization, just opening the cavity, evacuate the contents, and suture the walls of the cyst or the tumor to the surrounding mucoperiosteum. So 3 things has to be done in our marsupialization. It causes the decompression. Second thing is enucleation. Enucleation is the removal of the cystic lining. But both, mind you, both these things, marsupialization and enucleation, they have a high recurrence rate. So when we carry out enucleation, it should be added or incorporated with some other techniques, like one is peripheral osteectomy. That means the surrounding bone about 2 millimeters may be trimmed off using a acrylic trimmer bar or a rotary instrument. So that with the rationale is that some tissues may get engulfed in the surrounding bone. So we are not leaving that, we are just removing it with peripheral osteectomy. Second thing, the use of cautery agents. It can usually we have the liquid nitrogen therapy or Carnoy solution. In liquid nitrogen, we are using the liquid nitrogen by using a cryoprobe or nitrous oxide probe, maintaining the nitrogen almost at -186 centigrade. So when you apply this cryosurgery, what happens is that there is a formation of ice crystals, both intracellular and extracellular. When these ice crystals are formed, they causes an osmotic imbalance or electrolytic imbalance, and thereby the cell undergoes death or cell apoptosis occurs. This is what we achieve through liquid nitrogen. But the disadvantage is that it weakens the bone. So you can encounter a pathological fracture in future. So that is the disadvantage of liquid. But we are all favorite of Carnoy solution. We apply this Carnoy solution after enucleation. So these are some of the literature support, especially the first one. There is a recent one of 2021 describing the various use of Carnoy solution and its modifications to reduce the recurrence in both OKC as well as amyloblastoma. So what does this Carnoy solution does? It is actually a combination of glacial acetic acid, chloroform, and ethanol in the ratio of 1:3:6. But chloroform is carcinogenic. So it has been removed and replaced by ferric chloride. So we call it as the modified Carnoy solution. So this Carnoy solution is applied after the cyst enucleation. But there are literature support that it can be applied before the cyst enucleation. You call the term tanning effect. But most of the surgeons prefer to use Carnoy solution after the enucleation. And Wurtsmith has conducted extensive study and found out that the depth of penetration in the bone is 1.54 millimeters and nerve and mucosa respectively 0.15 and 0.51. So it causes fixation of the tissue, it causes the cauterization of the tissues, and even it acts as a hemostatic. So it destroys the cells. But the problem with the Carnoy is that it is a non-specific fixative. That has to be remembered. It cannot delineate whether it is a tumor cell or a normal cell. So it destroys both these tumor cells as well as the normal cells. That's why we need to keep it less than 5 minutes. There are studies that prove that when you keep the Carnoy solution in touch of the soft tissue more than 5 minutes, it causes irreparable damage of nerves as well as blood vessels. Especially when the mandible, when you use it, we are so concerned with the inferior alveolar nerve. So always limit the use to 2 or 3 minutes and then wash off the cystic cavity with saline. So coming to the surgical, it's a gold standard. We have the radical surgery, that is with en bloc resection, or you go for a margin with segmental resection. So if you can maintain the lower border, we call it as the en bloc resection or marginal mandibular resection. But sometimes it may be very difficult to maintain it, so we have to go for a resection. And in the resection, the recurrence rate is almost 2 or 3%. Whereas in the case of marsupialization, it may be 60 to 70%. Once you use the Carnoy, you can drop this recurrence rate to almost 16 or 17%. So in maxillary tumors, it's found to be more aggressive because we saw that it is a spongy bone. It has no anatomical confines, can easily cross to the neighboring structures, and thereby important structures like infratemporal fossa, orbit, or base of the skull can get invaded. So what are the current perspectives in surgery? Initially, we were just removing the bone and putting a reconstruction plate. But now with the technology, we can use a computer-assisted surgery or 3D virtual planning. In 3D virtual planning, we can assess and determine where the osteotomy cuts should be placed. They will supply, we will take the CT scans, we will send it to a laboratory. They will even prepare a cutting guide so that you can place that cutting guide and you can put the osteotomy in the correct position so that the defect can be easily predetermined. And based on the defect, you can plan the reconstruction also. Here you can see that most commonly we use the fibula graft. So when you go for the resection of the mandible, at the same time, we plan the reconstruction of the mandible, reconstruction by using fibula graft. So these similar cutting guides can be used in the fibula so that the adequate length or the measurement of the fibula can be made. The fibula is harvested and the fibula is easily getting incorporated in the defect area and it is fixed with the remainder bone. And even implants can be placed and prosthetic rehabilitation can be achieved so that the morbidity is reduced or the patient can get a good quality of life. So these are the things that are happening in nowadays because of the eye technological impact. So these are some pictures that give you an idea that we cut the mandible in the predetermined fashion, we estimate the defect, and based on the measurement, we take the graft, and then with the graft can be easily getting in a precise manner incorporated into the defect area. So this is one of the cases that we did in our department where the patient came with an ameloblastoma. You can see the multilocular appearance. We just did a resection, maintaining a ramal portion. We put a reconstruction plate, but unfortunately recurrence happened again. So we have no way to save the condyle. We removed the entire thing. We put a reconstruction with TJR, that is total joint replacement. So apart from surgical, we can have the medical management or we can have a radiotherapy. But these are things useful only in cases of metastasis lesions. Localized ameloblastoma, there is no role. The rationale is that the metastatic lesions are highly sensitive to platinum-based anti-cancer drugs. So you have a wide variety of drugs like cisplatin, cyclophosphamide, then vinblastine, vincristine, etc. So this can be used in the case of a metastasis. Then inhibitors, we have already seen that there are two pathways, MAPK pathway and sonic Edgecock pathway. And we saw the mutations of it. Just remember that if there is a mutation of the BRAF gene, and if you have an inhibitor for this mutated gene, definitely you can control the lesion. That is, vimurafenib works in that manner. It acts on the mutated BRAF gene. Similarly, if you have a mutation in the FGFR2, you can go for an inhibitor like ponatinib, which will control your disease. So inhibitors plays a very important role, especially if you can prove that there is a mutation in the ameloblastoma. Similarly, SMO mutations. We saw that in the sonic Edgecock, the SMO getting freed from the influence of the patched gene, so it goes uncontrolled proliferation. So you can go for drugs to combat the SMO, that is vismodegib works in this manner. So certain drugs can play a role, especially when you can identify the molecular markers. Cyclopamine is another widely used, which causes the osteoplastic proliferation. Okay, do radiation have a role? Only in inaccessible cases or inoperable cases. Imagine a very gigantiform ameloblastoma in the maxillary component extending to the base of the skull, infratemporal fossa. The surgery is not possible. You can think of radiation which can be delivered either by image guided or intensity modulated or even proton beam therapy. So, but I would say that thanks to these beautiful words by Robert E. Marks, the best chemotherapy for odontogenic tumor is a jar of formalin, nothing more than. So surgery still remains as the mainstay in managing ameloblastoma. Now I would think that I will move to the odontogenic keratocyst. So no other lesion in the literature has undergone a long journey in the nomenclature like OKC. It started with John Hunter's nomenclature of dental cyst. In between, it went into a cyst Then it was characterized in a tumor category, again brought back or rechristened into a cystic variant. So it has undergone a lot of changes. Why? In 2005, the cyst was converted to tumor. The reason, because it reflects the neoplastic property. And a lot of other reasons can be attributed. Why the decision was made? Because of its behavior, its growth rate, the histology, genetics, and immunohistochemistry. What about the behavior? It was locally destructive, very highly recurrent, high aggressiveness, and the recurrence rate may be amount to 3 to 60%. And sometimes it may be a part of the syndrome. So the behavior made him to think of whether it is a cyst or a tumor. Coming to the growth, its mitotic count is almost similar to ameloblastoma. And it proliferates not by osmotic expansion, but by the proliferation of the wall within the lining. So they thought that it is not a cyst, it's a tumor. And you may be able to delineate the presence of markers. So the protein content is less than 4, and some of the markers were found out, especially you can see the presence of patch G. Elucidation of this SMO SHH made to feel that it is not a cyst, but it is a tumor. Because of this, in 2005, it was categorized as a tumor component. And the presence of P53 or matrix metalloproteinases. So these things clubbed together, and WHO made a decision to carry it into a tumor component rather than a cystic counterpart. But in 2017, it was baptized again back to cyst. The reason is that the evidence supporting its tumor hypothesis was totally insufficient. So it is considered to be a cyst again now in the literature. So we have this definition of odontogenic cyst characterized by thin regular lining of parakeratinized stratified squamous epithelium with a palisading hyperchromatic basal cells. So basically, it is the molecular thing that happens. We have already seen that there is a gene called patch gene that is in the sonic hedgehog pathway. This patch gene always have a repressor effect on SMO. So SMO remains under the clutches of patch gene. But imagine the patch gene undergo mutation. It frees the SMO. The SMO is free from the clutches. It can independently work. So it releases the SMO. SMO began to do an aberrant work, uncontrolled proliferation and survival of the cells, and thereby a growth occurs in an uncontrolled fashion. This is the basic reason of this, especially when it is related to a syndromic cases. So 2 to 4th decade, some literature say that there is a bimodal distribution. You see the first peak at the age of 20 to 30 and second peak at 50 to 60, male predilection, mandible with more affinity for the posterior area. So we have these two groups, syndromic and sporadic. Syndromic and sporadic. And what are the syndromes associated with it? We are all familiar with the Gorlin box, but when you search in the literature, you can see that syndromes like Noonan, Marfan, Simpson-Golabi, orofacial degenerative, these are all associated with, in one way or other, the presence of multiple OKCs. So this is a beautiful literature support recently published in 2022, giving an extensive detail regarding, especially by Stoilinga, who has been one of the pioneers in doing research in the OKC, especially the surgical approaches. So where does the OKC takes its origin? Toller says that it is from the dental lamina. So Toller reiterated the nomenclature of laminar cyst since it takes its origin from the dental lamina. But Gorlin says that it is derived from hamartias. So it takes the origin from two separate things. So this is the one that we are so concerned. In ameloblastoma, usually it is a buccolingual expansion. But in OKC, it always an androposterior expansion. So that is why it is not detected in the early days. So initially, Donoff says that it was the collagenase activity that is responsible for the androposterior expansion. But Toller gives a beautiful description why this occurs in the anteroposterior direction. It can be due to the intraluminal hyperosmolality, active epithelial proliferation taking the course in the least resistance path, collagenolytic activity of the cyst wall, and the presence of interleukins 1 and 6. So this makes the OKC to move in an anteroposterior dimension. Radiologically, we come across the 4 types. It can be the replacement, it can be the envelopmental, collateral, or extraneous types. And you go for an aspiration, you get a dirty, milky white semi-fluid. The protein content when undergone for electrophoresis is less than 4, and mostly albumin is present. You can go for newer techniques, estimation of KCA, keratocyst antigen, lactoferrin levels. Immunohistochemistry is very useful to demonstrate the presence of cytokeratin, and if it is associated with the syndromic cases, we can demonstrate P53 presence. So, similar to Vickers and Gorlin, OKC as a criteria proposed by Scheer and Pinberg, very old one. In the literature, it comes in 60s, but still remains important. But now we have this Kagerman's pathological grouping. Based on the satellite cyst, we told that the group 1, that is without any satellite cyst, 63%, and a few satellite cysts and microcysts accounting to 10 to 27% group 2, and abundance of satellite or daughter cysts you club into the group 3 by Kagerman. So again, we have the options, the surgical being the gold standard, and here we can go for a conservative or a radical. In the conservative, we have already discussed about enucleation and marsupialization, but considering the high recurrence rate, enucleation should always be accompanied by adjunctive methods. You can go for a chemical cautery by Carnoy solution, which we have discussed in detail, and now we are using 5-fluorouracil also because of the anti-mitotic activity. Lot of literature comparing Carnoy solution and 5-fluorouracil. They excellently work, help to reduce the recurrence. You should also do a peripheral osteectomy to reduce the chance of the recurrence. But in some cases, the last resort is to go for resection. If the patient comes with a multiple recurrences, extensive soft tissue invasions and multiple perforations, and you see the thing has gone up into the ramus, condyle, coronoid areas, you have to undergo resection, because from there it is very easy to jump into the infratemporal fossa. So the last resort is the resection with reconstruction. So why this sonic hedgehog pathway is important? You have seen that there is a mutation of the patch gene that releases the SMO. So imagine if you have these agents in your hand. So to block the SMO is free, just producing aberrant result. So if you can block the SMO like a drug using cyclopamine, you can easily control the lesion. Similarly, if you have some inhibitors of sonic hedgehog pathway, or using a wild form of patch gene, so that it will compete with the mutated patch gene. So these are various things that has been described in literature, but we never found it be useful since we always go for the surgical option. So some untoward incidents can occur from OKC. The one is the development of squamous cell carcinoma. Why this occurs? According to Brown and Gouch, there is a keratin metaplasia initially develops. This is followed by hyperplasia. This is followed by epithelial dysplasia. So, and Van der Waal has proved that the presence of keratinization cyst lining is a dangerous sign. So, or sometimes it may be due to the long-standing chronic inflammation supporting the conversion of the OKC into a SCC. Similarly, you can encounter ameloblastoma areas within the OKC, but it's very extremely rare. Only 8 cases have been published in the literature, and IHC refers the presence of calretinine. And proliferative markers and also can occur. Why this OKC is a troublesome? Because of the high recurrence chance. You come a lot of things that causes the high recurrence. And Nakamura says that basically it's a thin, fragile lining. You may not be able to completely remove it. And some of these tissues getting entrapped in the bone where it remains unnoticed or undetected. So it can go for a recurrence. And also the presence of the satellite cyst or the daughter cyst and high mitotic potential. These all club together, making it a dangerous thing. And this Blue Book of 2022 gives an extensive description about the odontogenic lesions. So to finalize, When you go through the various manuscripts, you come these terminologies like enigmatic ameloblastoma, incredible OKC, lot of things. Why? Because these are things that are very difficult to manage because of the high recurrent rate. So Yang, we have already come across his name in the staging of ameloblastoma. He's in his literature, he gives a caption that there should be a plan for recurrence-free survival. And he has even published a nomogram that will help to predict what will be the recurrence-free survival of that individual. It takes into consideration the type of the lesion, the treatment time elapsed, the radiological, the histopathological variation, etc., taken into consideration, and you can even predict the recurrence-free survival. So our main aim is that when we manage these lesions, whether it's ameloblastoma or OKC, they are all dilemmatic conditions, but the main aim is to prevent or reduce the recurrence. So thank you for this patient hearing.
Thank you so much, Dr. Bobby, for that wonderful presentation. And you have contained the entire comprehensive details of ameloblastoma as well as rhabdoid keratosis within the specific stipulated time as to your presentation. And you have also given us a lot of good inputs too. Now, any questions, any queries in the chat box?
We're getting a lot of responses. It's an excellent presentation. The chat box. Thank you, Dr. Bobby. It was a wonderful and a detailed description about ameloblastoma, including all the aspects like the all pathology part and all surgery part, and also about the pathogenesis. You've gone very much in detail regarding ameloblastoma and OKC. It was a wonderful presentation. And we are getting a feedback that it was an excellent presentation from so many people.
Thank you, ma'am.
Thank you, sir.
Any questions in the chat box? Anything? I can't see any. Anina, can you see any questions in the chat box?
No, sir. So far, there are no questions in the chat box. Only appreciation and thank you, sir, that it was an informative session.
Oh yeah, Dr. Bhumika has asked a question. Can we get back with how squamous cell carcinoma transformation from OKC, that slide of yours, can you just share that slide alone, Bobby? Is it possible to share that slide alone? That you were telling the possibility of the keratin pearls and the keratin in the lining of OKC's common factors. What is it that actually makes OKC possibility to become a squamous cell carcinoma? Something what the literature says. We don't know the details, but can you just show that slide once again, if it's possible?
Yes, and I'm trying to share it.
Yeah, yeah.
Can you see?
Yeah. Yes, Dr. Bhumika was the person who asked this question.
Yeah, that it is found that the presence of the keratin there, it undergoes a metaplasia, then hyperplasia, and finally it goes into a dysplastic stage. From there, it takes the route into the squamous cell carcinoma. That is a literature support.
And there was one more question, I think. Anuna, can you read that last question?
So for how many years there should be a follow-up taken as OKC has high recurrence rate? How many years there should be
recommended? Is there
Yeah,
any recommended?
Some literature gives a protocol that the initial period, every 6 months, they have to be reviewed. That is extended up to the first 5-year period. And after 5-year period, it can be an annual review. There are contrasting advices also, because some people say that the recurrence occurs after 5 years. So limiting to annual one will be dangerous. But usually we follow that in the initial 5 year, every 6 months, we will review the patient and will take a radiograph to see whether there is any evidence of recurrence.
Thank you. I see more questions. Is there an evidence or is there literature which reports about a case turned to squamous cell carcinoma from the OKC, or is it just a probability what the literature is telling, or are there any case report or any
Yes,
such
yes.
evidences? Yeah.
Yeah, there is a case report, a rare occurrence. That is, I think that Journal of Imaging Science in Dentistry.
Yeah.
Imaging Science in Dentistry. There is an journal where it was a rare occurrence, squamous cell carcinoma arising with OKC. It was by Elnas Jalali.
Okay, there is one more.
Elnas.
There is one more question, sir, from Dr. Rajiv. He's asking whether there are any reconstructive options.
Reconstructive options.
No, he has already covered. He has already covered the reconstructive options there.
So you can start with the reconstruction plate, then you move into the flaps or fibula-like flaps. That depends on the center where you are working. So if you have a very close association with the plastic surgery department, you can go for the reconstruction with using graft or flaps. Or other cases, we just settle down with the reconstruction plates alone.
There's
Again, yeah, Anina, please. Yeah.
There's one more question from Dr. Divya. Does targeted therapy of BRAF gene reduce the need for mandibular resection in amyloblastoma? Does the gene therapy reduce the need for mandibular resection in amyloblastoma?
But I think that if it is an extensive lesion and it's almost near the lower border, there is no other options, only to go for a surgery. Only if you find it out in the initial stage, and if there is a mutation occurs, and if you can able to prove that mutation, then only this targeted therapy will be useful. But I don't think that we do not have this personal experience of using this targeted therapy. Maybe in higher centers they may be using it.
I hope that particular point is very clear. In the early stages, when there is a possibility of reverting this particular mutations, only that time this type of targeted therapy is in use. But then, in a fully blown established case, there is seldom any use for this targeted therapy. Yes, anybody else? I think this is one of the sessions where we had. Yeah, it's coming up. People are waking up, Bobby. People are waking up more and more queries. If after resection of amyloblastoma, can there be misdiagnosis with scarring? That question is not clear, Dr. Mrudala. If after resection of amyloblastoma, can there be misdiagnosis with scarring? That question is not clear. We'll move on to next. Dr. Mrudula, are you there? Can you just unmute yourself if you want and speak what is your query about? We are asking something about resection and after that and some misdiagnosis and scarring.
Good morning, sir.
Yes, please. Your question.
Yes, sir. Yes, sir. Sir, after the resection of amyloblastoma, that can be recurrence of the amyloblastoma also.
Mm-hmm.
Yeah. So after that, for when the patient has been follow up, and then if we take radiographs or imaging has been done, can it be misdiagnosed as amyloblastoma when there is a scarring, and it can be misdiagnosed as amyloblastoma? If we can just differentiate between the two, if it is just healing phase or it is a recurrence. Can you
So I think may I repeat your question and tell me if I am correct or wrong.
Yes.
Now what you're talking is
Yes,
case of amyloblastoma, you have done a resection, and later on during the healing phase, later on when you take an X-ray or something, you get to see a lesion developing there. Then you are telling can we call that as a recurrent amyloblastoma, or is there any other investigation we should follow up like a biopsy to consider that as a recurrent amyloblastoma, or can it be some other lesion? Bobby, you got the question. Can you just throw some light on that?
Yeah. In the repeated review, in the periodic follow-up, we usually take a radiograph and we see that whether the lesion size is decreasing, or sometimes it may be remain in a static form. After a few months or a few years, Suppose you see that the lesion is not healing, or you see the lesion in a different location, definitely it is not a part of the healing. So you have to go for a biopsy, or you can just wait and see whether the lesion is increasing in size or not.
Any other questions? We have time. We have time as per the schedule. Is there any further questions? A few of them have actually thanked the speaker for giving them a nutshell, the entire OKC and amiloblastom in a nutshell, because this is one of the most frequently asked questions as far as the final year MD is concerned. And you have made their work more easier by giving them a nutshell about this details altogether. Yeah, there's another one question. Anuna, can you just read that last question?
Can you, this is from Dr. Anu Ramchandran. Can you enlighten about peripheral osteectomy in OKC?
Yeah. Whether it is in the ameloblastoma or OKC, we do a enucleation first. That is the complete removal of the lining. Then with a rotary instrument, imagine that we are using a burr, that is a larger one, acrylic trimmer. Usually we go for that acrylic trimmer. You just run this burr or this instrument through the walls of the cyst. The assumption is that some tissue may get entangled or engulfed in that areas, because naturally, because of the resorption, some lacunae or some crevices will be there in the bone, and these soft tissues may get impregnated in these crevices. So even if you try to remove the entire lining in toto, some fragile tissues may be remaining there. So in order to avoid a recurrence, we will run this acrylic trimmer bar or any instrument through these walls of this cyst, through the bone, so that we may be able to remove this. Some literature say that use of methylene blue. So after removal, you coat these walls with a methylene blue so that you can identify the area where there are tissues. And these tissues can be easily removed with a rotary instrument. So you are removing the lining as also some of the soft tissues if they are present in the crevices of the resorbed bone, so that you can reduce the chance of recurrence.
One last question before we wind up. Can bone graft be placed at the enucleated site to strengthen the remaining bone? Just for strengthening, when you after enucleation, can bone graft be placed? If so, what type of a graft?
You can place bone graft, but there is a problem that it will mask the chance the recurrent lesion if occurs. That is a problem with it.
Thank you. So with that, we come to the end of a wonderful another lecture of the day 2 of OOO conference. I would like to thank the moderator. Sorry, I am the moderator. We are the moderators. I think I would like to thank the speaker. I think over to Meka. She's going to further do the Thanksgiving work and the certification part. Meka, you are there?
Yes, sir. Thank you so much.
Yeah, please take over.
Thank you, Professor Dr. Bobby John, sir, for this very enlightening session. I would like to thank Professor Dr. Ethan Thomas, sir, and Professor Dr. Anuna, ma'am, for moderating the session.
Thank you.
Thank you.
Thank you.
Kindly accept the token of appreciation.
Thank you.
First, I invite Professor Dr. Bobby John, sir, to accept the token of appreciation.
Thank you.
Sir, could you please, Dr. Bobby,
Stop sharing. Dr. Bobby, can you stop sharing?
Yeah.
Yeah.
Thank you, sir.
Thank you.
First, I invite Professor Dr. Bobby John, sir, to accept the token of appreciation.
Thank you.
Now I invite Professor Dr. Ethan Thomas, sir, to accept the token of appreciation.
Thank you.
Now I invite Professor Dr. Anuna Leela now to accept the token of appreciation. Now I'd like to invite our speaker for the third session, Professor Dr. Ranganathan K. Sir, Head of the Department, Oral and Maxillofacial Pathology, Ragas Dental College, Chennai, to present on the topic, Clinical Pathological Correlations, Interesting Cases. Welcome, sir. I would also like to welcome Professor Dr. Rakesh Suresh, sir, and Professor Dr. Reddy ma'am for moderating the session. Professor Dr. Rakesh Suresh, Head of the Department, Oral Pathology and Microbiology, Vice Principal, Amrita School of Dentistry, Cochin. Welcome, sir.
Thank you.
Professor Dr. R. Reddy ma'am, HOD, Department of Oral and Maxillofacial Pathology, Vice Principal, Associate Dental College. Welcome, ma'am.
Thank you.
Now, I would like to request Professor Dr. Rakesh Suresh, sir, to introduce Professor Dr. Ranganathan, sir, to the session.
Thank you. Good morning, one and all. At the onset, I would like to thank Dr. Sunil and the entire team of OOO for having given me this wonderful opportunity to introduce someone whom I admire a lot, and Dr. Kannan Ranganathan, Professor and Head of the Department of Oral and Maxillofacial Pathology, Ragas Dental College, Chennai. Sir completed his BDS from Madras University in 1987. He went on to finish his Masters in Oral Pathology and Microbiology in 1990 from the Tamil Nadu Dr. MGR Medical University. In 1996, Sir obtained MS degree from Ohio State University, USA. And in 2010, he was awarded the PhD from the Tamil Dr. MGR Medical University. Sir has been a fellow of the American Academy of Oral and Maxillofacial Pathology in 1995 and a fellow of Indian Association of Oral and Maxillofacial Pathologists in 2010. Sir has held many coveted posts. Currently, Sir is the president of the Asian Society of Oral and Maxillofacial Pathologists. He has also been the honorary secretary of our own Association of Oral and Maxillofacial Pathologists for 2 consecutive terms from 2008 to 12. Sir has been a PhD guide under the Tamil Nadu MGR Medical University, Sri Ramachandra University, Sri Balaji Vidyapeeth University. Sir is the member of the Institutional Advisory Board of T.T. Ranganathan Clinical Research Foundation and Outreach Center, and also in the International Steering Committee on Oral Aspects of HIV and AIDS. Sir has got many academic and research awards throughout his career, some of the most important ones being the Colgate-Palmolive Scholarship, the University Gold Medal for the Best Outgoing BDS Student, the Bennett Graduate Research in 1984 from the Ohio State University, and the Best Teacher Award from the Tamil Nadu Dr. MGR Medical University in 2011. Sir has around 187 publications to his credit. He has contributed to 4 textbooks, presented at around 100 invited lectures, both in the national and the international fora. And Sir's area of interest include cancer, pre-cancer, oral submucous fibrosis, HIV, and stem cell research. Now, apart from all this, a very passionate academician, a passionate oral pathologist, and an excellent human being, a person whom we all adore, admire, and respect. Ranganathan, sir, I humbly request you to take over the session.
Very, very good morning to you all. Can you hear me? Am I audible?
Yes, sir. Perfect.
Yeah. Thank you very much, Dr. Rakesh, for the very, very kind introduction. Before I start, let me thank the organizers for having made it possible to share some time with you all this morning. And my personal thanks to Dr. Sunil, who has been very meticulous, one of the best organizations I've seen in the recent past, exactly telling me when to log in and what to do, and, very methodical. Thank you very much, Dr. Sunil.
Thank you, sir.
And it's always a pleasure to share the dais with both Dr. Rakesh and Dr. Rati. We go way back. Thank you once again. Can I start sharing my screen?
Yes, sir, please.
How do I do this? Just hold on. Do you have to allow me to do something, or? Is the screen visible?
Yes, sir, it's visible.
Awesome. Once again, let me thank you all for having, given me this opportunity to share some time with you all. I think this is an excellent forum. And I think if at all you have a meet, we should have all these three specialties together. That makes a lot of sense, actually. On the other hand, it's very, very challenging to talk to this forum because you have surgeons, you have oral medicine people and oral pathology, and to get the right balance between having, a lot of pink and blue slides and clinical cases and the treatment is always challenging. So what I normally like to do in such an elite forum with, from different specialties is, one way to go about it is present some interesting cases, some challenging cases, and, make it very interesting. Another way around it is to emphasize the principal concepts of diagnosis and patient management. So that's what I'm going to do here today. We're always, being told history is important, radiograph is important, you need all the features. Let me see if I can emphasize each of these points with some interesting cases. The other thing I would like to say before I start is all these cases have been referred to me by some consultant or a practitioner or in the college context. So if anybody has got any specific doubt, you're free to raise your hands at any point during the presentation and ask me questions. Okay, normally when I do a CPC, and I do a lot for general practitioners too, I have usually this logo, and it sort of actually matches the logo which you have. So I thought that was very interesting that, we're all in the same page as far as that is concerned. So the importance of medicine and radiology, surgery, maxillofacial surgery, and of course, pathologists with their microscopes. We no longer are tethered to our microscopes. We have expanded our wings significantly. Let me see if I can show you some examples for that. Okay, these are some diagnostic caveats I would like to start, with. First, any diagnosis is a combination of clinical factors and pathological factors. By clinical, I mean history, radiographs, investigation, so on and so forth. Let's not lose sight of the fact that whatever we discuss here, whether from the aspect of surgeons, the oral medicine specialists, or the oral pathologists, the ultimate goal is appropriate patient management. And when these three specialties come together, everybody benefits, but the most important benefit goes to the patient because we can manage them optimally. And when it comes to cases, I always feel that there are three groups of cases, be it for surgery or in a clinical context. Some of them are very straightforward. You have an amyloblastoma, you have an odontogenic keratosis, and it's pretty straightforward. Textbook treatment pattern, textbook management pattern. Then you come across certain lesions where you have absolutely no clue what it is. And you're just scratching your head. You don't know what it is. You need specialists. You don't know where to start, whom to go to. And we get a lot of that in pathology, especially as you get on in years, we get all the difficult cases. And I'm sure that's true for very many seniors in other specialties. The next one is also very difficult. You have a lesion which looks classic, but you have a whole huge differential list. You can have an ulcer on the lateral surface of the tongue. I'll show an example of that shortly. And you can have about 14, 15 different diagnoses. What do you do from there? So all these three things are what you may face in a clinical context. Now, let me see if I can give you some examples for each of these. And once again, I'm sure this has been taught multiple times in this conference. Take the correct history, have the clinical and radiographic features, combine this with the histopathology, and then with the patient demographic features, you holistically approach patient management. And this is the fundamental algorithm in any clinical practice. So with that brief introduction, let me go on to something which right from our undergraduate years, which is drilled into us, take a proper history, take a proper history. Let's see how important this is. Now, this case is of a 54-year-old woman who was referred by an ENT physician for evaluation of a white patch in a soft palate. The lesion had been present for 4 weeks. It's been treated with antifungal medication. It was only mildly symptomatic. The size was huge. The patient was having some difficulty with swallowing, seen by ENT. This was one of the cases I saw when I was at Ohio State. So this underlines the importance of taking a good history. So this is a 54-year-old woman with a patch. The ENT surgeon had examined it, didn't have a clue what was going on, and referred to the oral pathology department. And what you're looking at is the soft palate, actually. This is the tongue, and you're looking at the soft palate. You see a nice white lesion, erythematous border, almost looks like lichen planus, nice white striae within the particular lesion. When we have a live presentation, I usually throw this open to see if anybody can, give a diagnosis. But given the format in which we are presenting, that may not be feasible. But given the short duration of a few weeks, the age of the patient, fungal infection is not a bad diagnosis, actually. But the patient didn't respond to antifungal therapy. And we went back when it came to us and took the history. Okay, before that, a biopsy was taken. And for the pathologist in the audience, this is basically a reactive lesion with a little bit of epithelial hyperplasia with elongated anastomosing retiridges, a very dense inflammatory cell infiltrate, and you can see a lot of leukocytes within the epithelium, so-called exocytosis. So this is a proliferative lesion where the retiridges are pretty long. The inflammatory cell infiltrate is lymphoplasmacytic, take my word for that, with a lot of infiltration into the superficial epithelial tissue. The point here is it's pretty non-specific. You could call it lichenoid mucositis. You may get a similar response to candidal infection. It's all these are possible. And for the pathologists around you, you're looking at a lymphoplasmacytic infiltrate. All these are plasma cells with a few lymphocytes thrown in. In the oral cavity, this is pretty non-specific, actually, because it's highly unlikely that you can take a biopsy anywhere in the gingival region or close to the gingiva oral mucosa without getting plasma cells. So it's really not that diagnostic. So we have a 54-year-old female patient with a white patch, not responding to antifungal medication. The histopathology is of a mildly proliferative lesion with a sort of a lymphoplasmacytic infiltrate. If anybody has a diagnosis, you can put it up in the chat box. Let's see if you can get it. All right. Given this sort of a clinical picture, we went back. This is the initial history page I had. We spoke to the patient. We asked one more question. What was her husband doing and what was his occupation? He was a truck driver. And the next logical question was, had he any time been tested for any of the sexually transmitted disease or STD? And she said, yeah, he's VDRL positive. And so what we can do is we can do a stain. This is a special stain. We can do what's called a Wattin-Starry stain or a Stainer stain. And you'll see these sort of elongated organisms. It's almost like a corkscrew appearance, tons of these. So you have a female in the 5th decade who's married with a white patch in the oral mucosa. This diagnosis is not the first one which pops into your mind, but when you club it with the history that the husband is a truck driver and has been tested positive for VDRL, and then you put in the histopathology and the staining pattern, you have the diagnosis right there. That's a case of syphilis. The second stage, this is what we call as the mucus patch. There's a saying, actually, if you read about syphilis and you know all the clinical manifestation of syphilis, you know 90% of general medicine, because this is a disease which can affect almost every system at different stages in life. Broadly, you can have what's called congenital syphilis. You can have a primary, a secondary, and tertiary. I'll speak very briefly about it in this context. Okay, let me see if I can, how do I put this off? I need to move so I can see what. All right, okay, that makes it. So these are the clinical features of congenital syphilis, and what we are normally taught at the undergraduate level are, let me see. It's not moving. Okay. These three, the so-called Hutchinson triad, which is the classic incisors, interstitial keratitis, which affects the cornea of the eye, and 8th nerve deafness. So in addition to that, you can get a bunch of maxillofacial features which may land up with the surgeon for cosmetic management. a lot of skin lesions, a lot of lesions of the joint and the long bones of the patient. So, but the classic one is Hutchinson triad with the features of Hutchinson incisors, ocular interstitial keratitis, and 8-nerve deafness. That's congenital syphilis. But what you're more likely to see are primary, secondary, very rarely tertiary, unless, if your patient is immunocompromised, then all these stages tend to, sort of happen very rapidly. The lesion of primary syphilis is actually a very painless ulcer called chancre with some regional lymphadenopathy. It can happen within 3 to 3 months, 3 days to 3 months of contact with an infected person. Move on to secondary is then that the patient starts developing systemic symptoms, pretty non-specific, almost like a viral flu, sore throat, malaise, tiredness. But in addition, you can get mucus patches intraorally, elevated lesions called condyloma lata, and these sort of split papules in the commissures, like what you see with B12 deficiency and iron deficiency. These are papules in the commissures with a little bit of ulceration. And these usually happen within 4 to 10 days of the infection, 10 weeks, that should be, I'm sorry about that, the infection. And you can have overlap of the primary and secondary syphilis. And then this disappears after 3 to 4 weeks. And then the patient is totally asymptomatic. And maybe a year or about 3 decades later, the patient can develop the stigmata of tertiary syphilis, which is the classic aneurysm and granulomatous reactions, what we call as the gumma. This is one case of syphilitic gumma of the palate, which we had in one of our HIV seropositive patients, actually. And you can see that there's absolutely no inflammation around the ulcerated margin, and the palate is completely perforated. So you can get similar lesions of huge ulcers or granulomatous lesion in the tongue too. This is syphilitic gumma, usually about a year or about a couple of decades after the initial infection. A point to notice, if the patient is immunocompromised, these stages get very compressed, and you may see a gumma even within about, a few months to 18 to 20 months after the primary infection. Now, they can accelerate the stages of syphilis. So if you're dealing with a HIV seropositive population or any population who are immunocompromised with superadded syphilitic infection, then these stages can be very rapid. There are tons of tests. We have what are called non-specific screening tests, which are 1 and 2. And then we have some highly specific tests, which are 3, 4, 5, and 6. The most commonly used ones are the non-specific tests, which we call as abbreviate as VDRL and the RPR test. And then you have different treponemal antibody assays. Either they could be agglutination, Hebe agglutination, or antibody absorption assays. These are highly specific and highly sensitive tests. A small note on diagnosis, you need to understand that there is a window period. So the patient may be infected, and they may be as long a period as 3 weeks before they become positive. So in this case scenarios, actually taking a good history is your best diagnostic feature. This is almost mandatory everywhere, especially in high-risk areas where the mother is tested prenatally for syphilis to make sure that, you can abort it at an early stage, prevent congenital syphilis in these pregnant women. And this is another big thing. Sometimes very early on in the primary stage and in immunocompromised patients, these tests may not actually become positive, or they may be very faintly positive. So once again, the results of these tests have to be taken in the context of how the patient is doing as far as he or she is doing as far as the immune system is concerned. The specific tests, namely the 3, 4, 5, and 6 of the previous slide, once they are positive, they may be positive throughout life, actually. So the patient is going to infect it the second time. These actually may not be really helpful at all. So these are some of the important points you need to remember when you're dealing with a patient who has a syphilitic infection. When I graduated out, and maybe about a decade back, we thought that you'd never see a case of syphilis, because thanks to the advent of penicillin and fantastic antibiotics and screening, and it's almost eradicated. But once again, we have seen a resurgence, especially with HIV infection and other immunocompromised states. So it may not be surprising if some of these patients land up in your clinical practice. And this emphasizes that no matter whether it's a married woman with no risk factors, You still need to take a proper history to make sure that you can diagnose STD such as syphilis, which can have protein manifestations, especially in the primary and the secondary stage. Okay, so that emphasizes the importance of history, importance of radiographs. This I cannot overemphasize, but I think that's not a problem today. In fact, we have the other problem. Patients straight away start taking CBCT and come to us. They don't have IOPAs or OPGs anymore, so straight away they take CBCTs, which can be a disadvantage actually sometimes. So what is the importance of it? And this is one of those, one of my cases which I've shown in multiple forums, and which always gives me sleepless nights because we think we have seen it all. I like to label it when I talk to general practitioners as when is a headache not just a headache. Okay, this is very, very interesting. This was a woman in the 4th decade. She complained of vague pain, swelling, headache, and swelling was on the left cheek, very diffuse, very subtle. She had seen multiple medical professionals, multiple medical professionals. She had seen ENT, she had seen neurosurgeons, a couple of general medicines, family physicians, you name it, she had seen all of them. And she had a huge list of diagnoses, treated for migraines, sinusitis, hormonal disorders, menopausal symptoms. She had treated for everything. And all of them had only a temporary relief, and then she had the same complaint which she had, vague pain, swelling, and headache. Well, the patient landed up in my practice, and I just took a look at this, and nothing very remarkable. There was a supra-eruption of a tooth here. But if you look very carefully, good oral hygiene actually, you can see some stippling here, but suddenly there is a loss of stippling here. And there was a very, 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 very subtle swelling. So headaches are always difficult things to handle, and especially when you have a woman close to menopause who has headaches with a lot of hormonal imbalances. It gets easily clubbed as psychosomatic or hormonal, and probably 70% of the time that's what it is. That's as a hormonal basis. But when you have a patient giving a symptom, and there seems to be an organic change in the site where the patient is pointing it out, then it's better that we investigate it. So this was the area actually. So this is a very, very, very subtle. The loss of stippling was pretty marked, and especially given the fact that the patient's oral hygiene is fantastic, we really had to do something for this patient. We took an OPG, and this is what we saw. You're seeing the floor of the maxillary sinus, and you can see this sort of nice mixed radio opacity, radiolucence. And this is recently extracted tooth, not healed completely, a little bit of supra-eruption. But the previous two, the last two molars had also been extracted, so 2.7 and 2.8 had been extracted. And the patient did say that that was a few years back, and it was an infected tooth. So probably, some sort of dense sclerosis, something like a sclerosing osteomyelitis, which has healed after the extraction. But the bone should resolve. I mean, you shouldn't have this sort of a lesion for a significant time after the extraction. When you go closer, it becomes even more prominent. So you can see this. There is a radio opacity, and you can see some sort of punched out osteolytic areas within the bone. Looking at the floor of the maxillary sinus, this is the first molar which had supra-erupted, and the end seemed to be a little bit jagged, not exactly healthy bone. But I still didn't have a diagnosis. The only diagnosis I had was probably sclerosing osteomyelitis, residual condensing osteitis, things like that. But that should not give the symptoms which the patient had. So what we did was we spoke to our surgeon colleagues, and I said, please go ahead and curate it. Because there are certain lesions which have been reported in long bones. We're not very sure it happens in the jaws. Some of you might have heard of that. It's called NICO. It's neuralgia induced by cavitational osteonecrosis of the bones. Our orthopedic colleagues diagnose these a lot, actually. So I had that in mind. The treatment for that was actually sort of complete curettage, revascularize the bone, and then it usually heals. So I had that in mind when I told the surgeon, please go back, go to the patient, open it up, curettage. That should make the patient feel better. Plus do give us some specimen. I'll just make sure, to sort of confirm that there's nothing else we are looking at. The surgeon went ahead, curated it. The patient had some relief, but not total relief. And to my surprise, I don't have too many histopathology slides here because I appreciate that this is a combined forum and you don't want to see too many pink and blue sides. And then we saw sheets of blue cells. In histopathology, actually, if you see a section which is very active with multiple different types of inflammatory cells, we are okay with that because that means a reactive lesion. But when something looks very bland and blue and uniform, and then we, sit up and start taking attention and start doing investigations, actually. So we did a whole immunohistochemistry panel, and we did a lot of panels, but what is relevant was it was CD3 positive, and some of you may recognize that as T lymphocyte specific. CD20 is a common leukocyte antigen, and CD68 is once again the immune cell marker. So these were all positive for immune cell markers, some focally positive and with diffuse positivity with CD68. I knew that we are dealing with a lymphoproliferative lesion. We referred it to our colleagues in Hem-Onc. They did a complete workup, and the diagnosis was actually acute myelomonocytic leukemia, FAB classification M4. An interesting extension of this clinical case history was we did a thorough examination of the patient. The patient did not have lesion anywhere else. And this was probably one of the earliest sites where it was diagnosed. The patient was treated appropriately, and a year after that, the patient was doing well. And then we lost the patient to follow up. And I'm very optimistic in thinking that probably she didn't have a recurrence and she's doing okay. And that's the reason why she didn't come back. So this case once again emphasizes the importance of, two things. One, sometimes when the symptoms are vague, definitely investigate, look at the radiograph very carefully. You really don't need fancy radiographs in the maxillofacial region for diagnosis. I'm not talking about treatment planning, for diagnosis. And three, when the symptoms are vague, but it sort of collaborates the site where the patient is pointing and there are organic visible changes in that particular site, no matter how subtle, no matter how vague the symptoms are, definitely investigate. That doesn't mean all of you go out of the session thinking that you have a headache, you should test yourself for leukemia. Please don't do that. And these are rare cases. And obviously we are doing that to emphasize the fact that when there are vague symptoms and signs, just don't brush it off by giving anti-inflammatories and not investigating. Investigate. Radiographs can be tremendously useful, and follow it up appropriately to make sure that the patient gets the best treatment. All right. So which comes to the third arm of this conference. We finished clinical history, radiology, histopathology. Of course, I need to talk a little bit about that. That sometimes, in spite of all your clinical and radiological features, but sometimes, I would say most of the times, you need histopathology as the gold standard for diagnosis, like in the previous case. So this is a very subtle case, just to prove the point that even what looks like a monotonous histopathology, if you don't understand the significance, you may trip on your diagnosis and patient management. And this was published, and I presented this in numerous forums to drive home this point that we should not be tooth specific. It's not oral dental health, it is oral health, which includes tooth and mucosa. A lot of times it gets lost in our concentration of the hard tissues that we forget about the soft tissues. I'm sure that's not true for this forum, actually. This was a woman in the second decade that actually come to our college with pain and swelling in the left upper vestibule. She had a very interesting history. She was diagnosed with amelogenesis imperfecta and had fantastic restorations done. So this is amelogenesis imperfecta, beautiful restorations, carspose, nice ceramic restorations. But now she has presented with this very, very prominent swelling in the vestibule anteriorly, in front of from extending probably from the lateral on the left, right side to probably the premolar on the left side. Huge swelling. And look at the radiograph, you can see a very, 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 very well-defined radiolucency on one side. Towards the midline, they're always difficult to take. And I think for the youngsters, this is how an occlusal radiograph looks like. I think people don't see occlusal radiographs anymore now that we have CBCT. In fact, I find it very difficult to get an occlusal radiograph in any of the centers, radiographic centers, and they look at like, what's occlusal radiograph? So anyway, this is one of those nice things which we have the privilege in an academic institution. And this is looking at the palatal view. You see a nice radiolucency. You can call it pear-shaped if you want, but not exactly pear-shaped. And it is associated with the root of the restored teeth, actually. Our surgeon did a fantastic job, neatly excised it out, and classic. I mean, you don't have to be a histopathologist to appreciate that. A lot of blood vessels and multiple giant cells. So this was a giant cell tumor. And the conservative dentist said, okay, fine, that's fine. It's not periapical granuloma. Our treatment is fantastic. So we've got nothing to blame. So it's just a giant cell lesion. It's a pathology. Said, what do we do next? And once again, what we do next is actually we drill it into our undergraduate students when you do oral pathology. I'll re-emphasize that. Whenever you see a giant cell lesion in the maxilla or the mandible, immediately say, do a parathormone assay. That's it. The diagnosis is not complete without line. So when I write a diagnosis of giant cell lesion of the jaws, my next line is rule out hyperparathyroidism. That's the next line. So those two go hand in hand. They're like twins. I mean, you have to make that statement actually. So this is called giant cell granuloma. I put it quote unquote. We use that term, but it's not a true granuloma. It's a giant cell lesion with a lot of blood vessels and giant cells. They're pretty straightforward, and these tend to be well circumscribed. And mind you, this patient was in a second decade, not a very old patient. Patient did have raised parathormone levels, and one of the easiest things that you can do in the clinical context is look for the blood pressure. It's general medicine and it's basic, because when parathormone levels are raised, you have altered calcium levels, affects renal function, affects the renin-angiotensin system, which in turn affects the blood pressure. That's a very good marker to look for renal function. And I'm sure almost all of you are aware that the first line of therapy for hypertension today is attacking the renin-angiotensin system. Many years back, it was trying to give centrally acting drugs like clonidine or a beta blocker. But now you have these ACE inhibitors. They all attack the renin-angiotensin system. So when you have an aberrant calcium metabolism and renal damage, the renin-angiotensin system gets affected, and then you get high blood pressure. In fact, the patient's blood pressure was off the charts, was something like 200 by 130 or 200 by 140, and she had not been diagnosed with high blood pressure before. We checked her renal function. She was going in for chronic renal failure. She had severe renal disease. And then we referred her to the nephrologist actually for further management, and she was being treated by the nephrologist. So this once again, it shows a cascade of events where the restoration was fantastic. The patient developed giant cell lesion, which was the earliest manifestation of imminent renal failure actually, and clinical context of blood pressure. And even if you had taken the blood pressure routinely, we'll tell our students to do that, but I think it's more often omitted than done. If you see a patient in the second decade with high blood pressure, you need to stop and investigate. There is no way you can know that it's the giant cell lesion by looking at the radiograph or by looking at the history, but it is a feature you need to keep in mind. There is another side to this story actually, which all of you should be aware. We went ahead and published this actually. We had two cases. There are studies which show that there is a close connection between amelogenesis imperfecta and renal disease actually. So if you have a case of amelogenesis imperfecta, it may be worth your while to at least do some basic blood investigations to rule out renal disease. Once again, let me emphasize that this is not common. This is not unusual, but it can happen. And it doesn't hurt to do routine investigations, hematological investigations to rule out early renal disease. So this once again is a case where a combination of the clinical features and the histopathology led to very, very early diagnosis of high blood pressure in a patient who was in the second decade and had severe renal impaired function and had chronic renal failure actually, and was referred to a nephrologist for management by the dental surgeon. Okay, so these three cases emphasize the importance of taking a good history, having a good radiograph.
Okay, I think my headphones have conked off. Can you hear me now? Am I audible?
Yes, sir.
Okay, I'm just going to use my laptop. I forgot to charge my headphones, I think. I'm sorry about that. Technology sometimes can let you down. Sorry about that. Yeah. And so these three emphasize these points. And then let me talk about a few cases. I think I'm well within my time. Yeah. Okay. Now, this was actually a postgraduate student in my institute. Sometimes things can look ominous, but they're not ominous. And these are one of those lesions where you have no clue what it is, but once you have seen them, you never forget it for life. These are called classic clinical manifestations. And this was a postgraduate from the endodontic department, actually. He walked into my room one day and said, I have this black lesion of sudden onset. And I knew he looks into his mouth because he's a conservative dentist. I'm sure he's periodically checking his tooth for pit and fissure caries and whatnot. So I knew he has looked into his mucosa very well when he was not imagining. And any rapidly increasing black lesion, the first thing that crops into your mind is melanoma. And these are nasty lesions, and you need to treat them at the earliest. So this was a dentist postgraduate with black pigmentation of the oral mucosa. And he was very sure that it was there only for a few weeks, but that rapidly increased. Was not on any medications. He claimed that he did not have any habits. And this is what we saw, a nice diffuse black lesion. Okay. For reference, this is the opposite side. So this is not a systemic problem where he gets multiple black pigmentations in different parts of the mucosa, which indicates a systemic issue. There are very many systemic conditions where this can happen. I saw this, and the only thing I asked him was, did you have any dental treatment done recently? And he said, yes. I had some glass enamel restorations put in my pit, and or class 5 restorations, actually. And I said, were they new? He said, no, I had some amalgam restorations and I had it removed. I thought the Minamata Convention and so many other things they're talking about, they want to phase out amalgam. So I thought I would put a, tooth-colored material there, which is a non-metallic restoration. And he said, probably this happened after that. Then immediately, I run it around my postgraduate students and they all were excited. Said, this is a case of amalgam tattoo. No, this is not a case of amalgam tattoo because amalgam tattoo takes years to develop. It's because the amalgam gets incorporated into the connective tissue and stains the fibers, the reticulin fibers and elastic fibers. So it doesn't have such a rapid onset. And the patient was, excuse me, very clear that it was very recent onset. Then I did ask one question. Was there any trauma when this procedure was done? I said, yes, they placed some cotton rolls when they removed it. There was a little bit of a laceration. I told him, don't worry, it will disappear in a month or so, just leave it alone. But he was very insistent. He said, no, sir, I want you to take a biopsy. I'm very, very apprehensive about this. I said, good. And I told him, if you take a biopsy, the moment I take a biopsy, it will disappear. And he was looking at me like, what? He took a biopsy, placed some nice sutures, and you will see that by the time the sutures are removed in a week, it is starting to fade off. Actually, wherever the sutures are there, it actually fades off. This is the lesion on your left. It has faded off. And I told him the diagnosis is, once again, some of you may have got this because we had actually published this a few years back. This is what we call as melanoacanthoma. This is rapid onset pigmentation. Interestingly, some of the earliest of these reports were done in periodontia journals, actually. When they do procedures and there is a trauma in the cheek, rapid onset pigmentation, usually associated with the traumatic restorative procedure or a dental procedure intraorally within a few weeks or days of the onset, but they are very self-limiting. And many a times when you take a biopsy, they will disappear. So this is basically an increase in the melanin secretion, not a proliferation of melanocytes, which are abnormal like in a melanoma. So this is what we call as an oral melanoacanthoma. And for the pathologists out there, you will see that there is a lot of intercellular space. And then when you do a special stain, this is a Mason-Fontana stain, you can see this nice dendritic process, almost spider-like. And these are classic melanocytes with very prominent dendrites and melanosomes. And this is the reason for the pigmentation. And because they are restricted to the surface epithelium, as the epithelium exfoliates, as there is a turnover of the epithelium, these lesions will disappear. That's the physiology behind why these lesions disappear, actually, because they are restricted to the turning over epithelium. And so they're pretty innocuous lesions. The only thing is, once you know them, you will recognize them. And even though it is black and rapidly increasing in size, nothing to be alarmed about, because that's what we teach students, actually. Anything which is black, rapidly increasing in size, yes, could be melanoma, but it has to once again taken with the correct history, correct location. If you do that, then you come to the diagnosis. And many times you can avoid scaring the patient and doing a biopsy, which may not be essential, but it doesn't hurt to do a biopsy if you need to confirm it. Okay. Now these are what I call new age lesions, and I need to keep myself updated. In fact, just last week I heard of a very, very new form of tobacco which is rampant, and I wasn't even aware of that, though I work with cancer a lot. So this is once again one of those cases which, if you're not up to with the present generation, you may miss this lesion actually. This was a 33-year-old male patient who had patches and burning of the anterior dorsum of the tongue. The burning got worse on taking spicy food. It's there for 3 months. Look at that. 33 years old, he's type 2 diabetic, not familial. Can you guess his occupation? IT industry. He works in the IT industry, sleeps at abnormal times, works at abnormal times. They have a very tough life. It looks very rosy from outside, but it's a difficult life. And he's already developed type 2 diabetes as a part of a metabolic syndrome, no family history of diabetes. And he had no habits. Okay, so this is what patient had. The patient came to be, you're looking at the tongue, multiple white patches and erosions. He had gone to multiple dentists, multiple specialists, given multiple corticosteroids, mucopain, and so much of topical anesthetics and curcumin and all sorts of stuff. He's been having for the, but he's seen about 3-4 specialists. But he says it numbs it for a few minutes and then again it starts to hurt. We took a biopsy because there are certain conditions like chronic oral stomatitis and diabetic associated lesions, which can look like this. The lesion is pretty non-specific for the histopathologist out there. Nothing. Mild inflammation, you can see that in mucositis. Maybe a little bit of a jagged surface, but you're looking at the tongue, so it can have a papillary surface. But what is striking is, let's say, intracellular edema and a nice split above the basal layer. Nice split, but without any inflammation, without any acantholysis, which may indicate an autoimmune process. So it's not acantholysis. This is not an artifactual tear because you can see all other areas, it is fine. Plus, many a times I work with the surgeon when they take biopsy, so I get the appropriate site, so we don't have to re-biopsy. So I know that the surgeon was very gentle with the tissues, didn't use a tissue forceps or anything like that. So this is not artifact. This does not look like autoimmune. Very minimal inflammation. And I had no idea what to call it. I had, just mucositis, non-specific, but what do I give this patient? He has taken all sorts of things, steroids, anti-inflammatory, antioxidants, you name it, he had taken it. I got the patient back to my chamber and then I started taking history. 3 months back, I said, what happened? What were you doing? He said, no, sir, I was traveling. The only thing I can remember is I had a party and I had this very new drink, which I've never had before. What drink did you have? And this is apparently very popular. I wasn't aware of this. These are what are called liquid nitrogen-based drinks, what are called mocktails with liquid nitrogen. And apparently you put it with the liquid nitrogen in your mouth and liquid nitrogen-induced burn. Then it struck me. I have seen this when I've been abroad. Sometimes over Christmas, they will send tissue specimens and it'll keep lying in the post office in extremely cold temperature. And because of the freezing, you'll get what's called a freezing artifact within the epithelium. But it's slightly different, but some sort of a similar, that you have an artifactual separation, but there the epithelium separates from the underlying connective tissue. So this is actually a lesion which got triggered by taking this sort of a liquid nitrogen based mocktail during a party, and this is a burn. And applying topical things was actually making it worse because when you have a burn, you keep applying things, steroids interfere with healing, prevent reepithelialization, lots of problems you have. So I told him, leave everything, gave him a very, very soft, soothing emollient, and just told him, just don't stick your tongue out and see, don't use your tongue cleaner, don't apply anything, just leave it alone and just apply the soothing agent. And within a few weeks, he was absolutely all right. And the good thing which came out of it is we scared him about his diabetes and he assured us that he's going to change his lifestyle and take care of his health. So this is once again to drive home the point that you may see new lesions because of new habits, and you need to be very aware of what is going on around you if you need to do good practice. Okay, This is one of those cases, once again, I saw when I was at Ohio State, and it's been published and it's in a couple of texts. This is once again a very, very unfortunate case, but all of you need to keep in mind, this is a patient who was diagnosed with diastema. It was having orthodontic treatment. The patient had diastema. It was a 17-year-old male patient. It's an African-American patient. A complaint about diastema of the maxillary anterior teeth. But the dentist, interestingly, noticed lumps on the patient's tongue. So it was referred to us. And you can see there are these small lumpy areas on the mucosa and lumpy areas on the tongue. You see that? And the patient had some lesions on the palpebral conjunctiva too. Not very well circumscribed lesions, actually. Took a biopsy of the lip lesion, of course, not the ocular lesion. And to the pathologists out there, this is pretty straightforward. Bunches of nerves. This is a neuroma. These are all bunch of nerves. And you look carefully, there's a thickening around each of these bunches, the thickening of the connective tissue around these bunches. So basically, you have bags of nerves surrounded by thick connective tissue sheath around some of these islands of nerves. They're all convoluted in different shapes. These are made of nerves, so it's a neuroma. It is in the mucosa, so we call it a mucosal neuroma. So multiple mucosal neuromas. This should immediately raise a red flag in your mind because this is a very, very nasty lesion. And very many a times it's diagnosed by the dentist. If you don't diagnose this, in fact, you may lose the patient. It can be that serious a lesion. This is what we call a multiple endocrine neoplasia syndrome type 2B. So whenever you get a diagnosis of multiple mucosal neuromas, this is it. And why is this important? Because almost all these patients have thyroid carcinoma, even before you diagnose it clinically. This is because of what is called a red proto-oncogene mutation. In fact, we diagnosed this, sent him for thyroid evaluation. By the time the patient, when he's 17 years old, mind you, 16 of the 45 cervical lymph nodes had metastatic medullary carcinoma of the thyroid. It was not diagnosed at that time. Okay, a little bit about this multiple endocrine neoplasia syndrome. There are two types, type 1 and type 2. Type 1 is pretty benign. It's tumors of the parathyroid, adrenal cortex, anterior pituitary, or pancreas. It's usually, there's a mutation on chromosome 11. Type 2 is what we are concerned about because this is where you get multiple mucosal neuromas. This is because of aberration in chromosome 10. There's a proto-oncogene called the ret proto-oncogene. It comprises of a group of 3 conditions, one which is familial medullary thyroid carcinoma syndrome, MEN2A, and MEN2B. Just a brief overview because of its importance and the fact that dental surgeons may be the first to notice it. MEN2A and MEN2B are the ones which are associated with risk of medullary carcinoma of the thyroid. This was 2B, this is a very particular mutation in the ret proto-oncogene. Almost all these patients go on to develop medullary thyroid carcinomas. So it's very imperative that you diagnose it early. And those of you who know about medullary thyroid carcinomas, these are nasty lesions, invariably diagnosed late, and are fatal. They're absolutely fatal if not treated early. So it's very, very important that you understand that. These patients do not have hyperparathyroidism. However, they can have gastrointestinal, ophthalmological, skeletal manifestations, one of which is marfanoid status. This patient was very tall and had a marfanoid habitus. But what is important as far as we are concerned is many a times you may get this on your table or you may see it clinically as mucosal neuromas, and immediately the red flag should go up of MEN2B and an occult silent medullary carcinoma of the thyroid, which if diagnosed early is got a good prognosis, but invariably diagnosed late and invariably it is fatal because those things are very, very difficult to manage once they metastasize. And that is the significance as far as oral and maxillofacial surgeons or pathologists or medical folks are concerned. Okay, so I think these couple of cases have emphasized history, radiograph, rapidly growing lesions, which may not be what they look like, and lesions which look benign, fibroma-like lesions, which can actually indicate a very serious underlying systemic problem, which emphasizes the fact that we have a very important role in diagnosis. It's just not diagnosing alveolar abscess and pericoronitis and ameloblastomas. You need to keep in mind that you can be very, 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 a crucial role in fact, saving the life of some of these patients, rare, I agree, but they may land up once in a while in some of your practices. And if you're aware of them, it can make a big difference to your patients. And of course, no presentation is complete without cancer. And I love this, poster from Greek mythology. We say cancer as protean manifestations. It's like the Greek god Proteus, who can take up any shape. They can be very tricky, especially for people who are starting their practice and the youngsters out there. I'll show you why they can be tricky. This is not a diagnostic problem. All of you can diagnose this as cancer, huge exophytic lesion in the buccal mucosa, another one in the floor of the mouth adjacent to the alveolar ridge, oral cancer, not a very difficult diagnosis. This is a very interesting case, and I like to point this to all my oral surgeon and prosthodontic colleagues. This patient had a very interesting history, and let me tell it very briefly. He had gingival problem, so had multiple periodontal work done. Then the tooth didn't respond, was non-vital, had a root canal restoration done, didn't respond, extracted under bridge put, severe bone loss, persistent lesion. And then what they did was the order of the day today, they placed some beautiful implants and put a restoration. Once again, massive soft tissue problem. Eventually, somebody thought it would be prudent to take a biopsy and send it across. The thing was taken, and this turned out to be a squamous cell carcinoma under the implant surface, actually. So we do not know when exactly the squamous cell carcinoma happened, but the patient eventually got a treatment done and became better. But the point here is, whenever you do a treatment, even though it does not look like cancer, it looks like a periodontal problem or just a benign ulcer. It's important to realize that you need to investigate, just like my second case of the headache. When you do a treatment protocol, which is a standard operating protocol for that particular disease, and it does not heal within 2 to 3 weeks, definitely investigate. Don't keep changing your medicines if you're following the correct SOP. Investigate. I mean, I can't overemphasize this. And this was treated, fortunately, and the patient did well. The other thing is oral submucous fibrosis, and that's one of my pet areas of interest because it's a uniquely Indian and Southeast Asian problem. Cancers can look very innocuous. That looks like a cancer, the previous case. This looks just like a fine red irritation area because sometimes when they choose areca nut, you can get a hypersensitive reaction like this. But this is an erythroplakia, and in fact, biopsy proved this to be an oral squamous cell carcinoma. So 2 things I want to emphasize. Cancer always does not look like a fungating ulcer. And in conditions like oral submucous fibrosis, it can be very, very, very subtle. The third thing, which I think we teach all our undergraduates is, if you have a red patch, what we call as an erythroplakia associated with what now we call as oral potentially malignant disorder, of which submucous fibrosis is one. Earlier, it used to be called precancer or pre-malignant. So we call it potentially malignant now. Definitely biopsy. Because anything which is an erythroplakia, at least in my book, it is a cancer unless you disprove it with a biopsy. Because erythroplakias have a very, very high rate of being a malignancy. So if you see an erythroplakia in a mouth with patients with habit or a potentially malignant disorder, the clinical diagnosis is erythroplakia, squamous cell carcinoma query. You take a biopsy. If it's not squamous cell carcinoma, everybody is happy, treat it appropriately. So these 3 points I'd like to emphasize. Cancers can look pretty innocuous, especially in conditions like oral submucous fibrosis. They won't have a typical appearance. They can take on a protean manifestation. And if it is erythroplakia, biopsy. Because I do hear a lot of argument about submucous fibrosis, should it be biopsied or not biopsy, and that's a topic for another day. But when you have lesions like this, definitely biopsy. Okay. I think I have still another 3 minutes. I think I can finish. Can I have those 3 minutes? Can I finish it off?
Yes, sir, you can proceed.
Yeah, awesome. This is a 60-year-old female patient with a 2.5 by 2.5 centimeter ulcer with elevated margins on the right lateral surface. It was indurated, the classic sign of squamous cell carcinoma, and was bleeding on probing. That's a nasty looking lesion, lateral tongue, gutter zone, lateral ventral surface, and you can see this nice sharp teeth. I wouldn't be surprised, or I wouldn't argue with you if you call it a squamous cell carcinoma. The biopsy was taken. the teeth was extracted. Actually, it healed very well. Absolutely healed very well, but there was still induration, a little bit hemorrhage here, a little bit there, but it healed very well. Maybe a mild keratosis, actually. This was a few weeks after the extraction. So when you have an ulcer like that, you have a huge differential diagnosis. All these can look like that. Granular cell tumors, primary syphilis, an anesthetic ulcer, squamous cell carcinoma, salivary gland malignancy, lymphomas, tubercular ulcers, cystoplasmosis, blastoma. They're not endemic to our country, but those all go into fungal infections, actually. Tuberculosis is probably the most common in our country, actually. So these are all good diagnoses. And of course, you have traumatic fibroma and traumatic ulcer. Those are all reasonable diagnoses. But what happened was we took a biopsy for the pathologist on there. There was no tumor, just mixed inflammatory cells with nice, beautiful red cells. It's nice, you can see them. I don't have to be a pathologist to realize that this nice red pink cells, can you see them? These are all what we call eosinophils. If you remember your physiology when you did your blood smears, those nice pink cells when you do a Leishman stain, tons of eosinophils. So you have a non-specific ulcer, heals after extraction or the irritating cause, removing the irritating cause, and it shows an ulcerated mucosa with tons of eosinophils. And the diagnosis is, that's a mouthful, actually. It's traumatic ulcerative granuloma with stromal eosinophilia. It's not diagnosis. I mean, it's not a cancer. It's not a malignancy, so you don't have to worry. What makes it easy is calling it tuxate. So sometimes, just like I said in oral submucous fibrosis, something which is innocuous can be cancer. Something which looks nasty need not necessarily be cancer. The point here is, as in, when you're starting your practice, I'm sure the seniors won't do this, but as a junior, just because it looks like cancer, telling the word cancer to a patient carries a very, very big responsibility. Don't use that word very loosely. You can always tell them there's a possibility that there are other lesions like tuberculosis, tuxate, which can look like cancer, which can have all the clinical features. You'll have induration, you'll have rapid growth, everything. But when you take a biopsy, it's not. So all that which looks like cancer is not necessarily cancer. Two, once again, you need to take a biopsy. Don't just refer the patient to a cancer center or something like that. Take a biopsy, make sure you're really dealing with cancer. Because it can be a lesion like traumatic granuloma. Could I stop?
No, sir, you can proceed.
Okay, I'm sorry. Histopathologically, for the pathologists out there, these sort of features, you can get an eosinophilic granuloma, angiolymphoid hyperplasia, and chimeras. Of course, they have other clinical manifestations. Atypical histiocytic granuloma, and of course, lymphoproliferative disorders, of which lymphoma is one of them. So these are all good differential diagnoses, but the classic mixed infiltrate with eosinophils clubbed with the clinical history, it's a no-brainer. It's a traumatic ulcerative granuloma with stromal eosinophilia. These ulcerations can be due to acute or chronic trauma. They have a pseudo-invasive inflammatory reaction. I'm almost on my last slides. Common sites are the tongue, lips, and buccal mucosa. They heal with biopsy and no intervention is necessary. The take-home message is they appear clinically neoplastic, but they can be reactive or inflammatory. And all that looks like cancer may not be cancer, and all that which looks innocuous is not necessarily benign. So the only way you will prevent yourself from tripping with these conditions is have a good clinical history, good clinical investigations. When in doubt, or even when not in doubt, biopsy, biopsy, biopsy. Otherwise, you will miss these lesions. And once we work together as, a diagnosis by the oral medicine folks, a fantastic biopsy by the oral and maxillofacial surgeons, and with our input as oral and maxillofacial pathologists, we will definitely come to a diagnosis no matter how difficult the condition is, and give the best benefit of, the best treatment to the patients. So everybody is happy, the specialist, the patient, and we learn something in the context which we can transfer for the benefit of our future patients. To summarize, history taking is very important. Investigation is very important. Lesions can mimic cancer, or cancer can look very innocuous. So have a very high index of suspicion. Follow standard protocols for examining the patient and investigating the patient. Just don't look into the mouth and jump into a diagnosis. If you are methodical, work with the specialists and do appropriate procedures, you can nail the diagnosis almost every time and treat the patient appropriately. so that everybody is benefited. Once again, thank you for sharing this morning with me, and hopefully you have benefited from this. It's been a pleasure talking to you. Thank you very much.
Thank you, sir, very much for the wonderful presentation. And it is like a take-home message for all the specialty. The emphasis made on the history taking, the clinical data, radiological aspects, and as sir said, even innocuous looking lesion, sometimes a serious underlying disease may be unveiled if you undertake a proper investigation and biopsy whenever it is required. Thank you, sir, for the wonderful presentation. For the three specialty equally benefited. Thank you, sir, so much.
Over to Professor Dr. Rakesh, sir, for discussion.
Thank you, Ranga, sir. Having listened to so many of your sessions earlier in our own specialty meetings and otherwise, you have always driven home the message that clinicopathology correlations are actually required. And this is, in fact, the right forum to once again propagate the same message, as you have rightly done with an array of cases from your own experience. Thank you, sir, for sharing with us those wonderful cases. I'm sure it's not the PG students alone, but even the faculty members who have gained from your expertise. Now, I think the floor can be open for discussion. Anyone with questions? So there are a lot of appreciating messages which are coming in. There is one message from Dr. Babu Matthew. He has actually said, it's very nice to meet you after 2 years.
Thank you. Thank
two
you.
long years.
My pleasure, sir. I share very fond memories of discussions with you. Thank you very much. You're a tremendous source of inspiration for all of us.
Not seeing any questions in the chat box. So Babu Matthew sir is here. Sir.
Hello, can you hear
yes,
me?
Sir. Yes, sir, we can hear you. Yes, sir, please.
No, I'm really fascinated by listening to Dr. Ranganathan's lecture. And he has taken us to 50 years back when the subject of oral medicine and oral pathology had its development as individual specialties. We all were working initially in institutions which were attached to medical college, and therefore we had free access to the various OPs, especially the specialty OPs, dermatology, ENT, etc. But the present day dental colleges which are not attached to medical colleges, I wonder whether they get chance to see the wide spectrum of systemic diseases with the oral manifestations. Some
I think there is
audio, please.
Issue with the sir's internet.
Thank you, sir.
So, any more questions from the audience? So I think, sir, we can wind up the session because we have lots of appreciating messages which are coming in, but no questions.
That's the best thing of presenting before lunch, you know, we can get away easily.
So thank you, sir, once again for that
and it
wonderful
was a
presentation.
pleasure to meet Dr. Babu Matthew after many years, sir. It's really an honor to see you on screen. I have great regards for you, and it is really nice. So it makes my day more special in addition to talking to you all. Thank you very much.
Thank you, sir.
Sir, can I have a question?
Yes, please.
Sir, one question is, I am a periodontist. So adjacent to crown and bridge, if there is a white persisting lesion which is not responding to antifungal medications, then what could the differential diagnosis be? Because in my particular interesting case, There are no dysplastic changes. We have done a biopsy, no dysplastic changes, and it is not suggestive of LP also. So what can be the other differential diagnosis that we should think about?
Okay, I presume that the white patch is only in that particular area adjacent to your restoration, right?
Yes, sir. Yes, sir.
Two things. I mean, there are multiple things which can happen, but two things which jump to your mind. And I presume you're talking about PFM, porcelain fused to metal?
Yes, yes, it is. It was a PFM crown and bridge, which was more than 10 years old.
Yeah. So what happens sometimes is earlier, many years back, they used to use chrome cobalt as the base metal, not nickel alloys. Okay. So one thing which the patient can look at is from probably changing the base metal or using a metal-free crown. I've seen that in a few of our patients actually, especially old restorations. That's one way to go. The other one, which is actually a very interesting takeoff, is the fact that if your contour of your crown is not very good, we do know that gingiva is keratinized because it's a frictional mucosa. Sometimes when the contour is not good when you're brushing or when you're eating, the way the food impinges on the gingiva, the way you brush, there may be what is called a reactive keratosis. But that will show in the slide actually. I have actually biopsies of traumatic brush ulcers which were biopsied. So if you look at the biopsy carefully and if you look at hyperkeratosis, that's one indication. But if you look and see eosinophils in the inflammatory cells, it's probably an allergic response. The patient will obviously ask you the question, I've had it for 10 years, why should it come now? There are two answers to that actually. The oxidative products may take very many years. Two, with age, the patient's immune system may get modified and now it may be targeting this. And we know that. We know patients who are not allergic to many things until they're 40 years, and after 40 years, they develop allergy to stuff which they've been exposed to earlier, including medicines. So if you look at the biopsy, one thing is to rule out cancer. One thing is rule out dysplasia, but cancer and dysplasia are not the only disease. There are tons of reactive conditions. Yes. But if you look at the inflammatory infiltrate, the pattern of keratinization, that may actually tell you whether it's because of trauma or an allergic response to the alloy there. That will give you that localized. And you are aware of something called fixed drug eruptions, right? So you can get allergy in localized areas. It doesn't have to happen in the entire mucosa.
Yes.
It may be a local phenomenon. I mean, those are two things I can think of at the top of my head. Obviously, you have to take other factors into consideration. Yeah.
Thank you very much, sir. Thank you.
Sure.
Thank you, sir. Assuming that there are no more questions, can we go back? Sir, there is one question now which has popped into the chat box. Sir, can you explain why the lesion of acute lymphomonocytic leukemia was radio opaque? It's from Dr. Sangeeta.
I know that the best thing I say is after I walk out of that presentation, people say I had headache for so many years. What do I do? I'm glad that nobody asked me that question. Okay. I don't know. See, you do have to understand that bone is very, very dynamic tissue. It responds to so many things. There are a lot of unanswered questions in that. It was a very atypical presentation. Two, after so many years of complaint, almost a year or two, there was only lesion in that particular area. For some reason, there was no systemic lesions at all. And I talked to the hem-onc people and they have no clue why that is so. Good for the patient. Three, this is my answer to the question, and I don't know what the answer is. These lesions don't read textbooks. So you have to take word for that. I mean, I could talk so many things. I could say maybe the rank A balance was lost. Maybe it was a low-grade lesion which led to stimulation of osteoblasts and osteoclasts. And you know that osteoclasts and osteoblast functions are interrelated in physiology. I could give you, but they are all hypotheses and probably just academic extensions of what we know. But the best answer in pathology is we don't know, because diseases don't read textbooks. For every classic condition which you give me, I can give you two classic conditions where it's just what is not mentioned in the textbook. To answer your question once again, I really don't know, but my gut instinct is it must have been a low-grade lesion, which gave some time for bone response, and the bone was trying to wall off the lesion, just like a fibrosis in a cystic area. That's probably we saw sort of sclerotic areas. With osteoporotic areas, if you looked at the high magnification, they were punched out areas of, bone loss actually.
Thank you, sir. Thank you, sir.
Yeah.
Thank you, sir. I think with no more questions, thanks to the organizing team once again for having given us this wonderful opportunity. Over to Mika for carrying out the rest of the certificate presentation.
Thank you, sir. Thank you, Dr. Ranganathan, sir, for this delightful session. And I would also like to thank Professor Dr. Rakesh Suresh, sir, and Professor Dr. Ravi ma'am for moderating the session. Dr. Ranganathan, sir, could you please stop sharing the screen now?
Okay, very good.
Thank you, sir. Please accept our token of appreciation here. Firstly, I invite the speaker, Professor Dr. Ranganathan, sir, to accept the token of appreciation.
Thank you very much.
Now I invite Professor Dr. Ravi ma'am to accept the token of appreciation.
Thank you.
I invite Professor Dr. Rakesh, sir, to accept the token of appreciation.
Thanks a lot.
Thank you, sir. Hereby, we come to the end of keynote lectures for the day. Requesting all the delegates to on the video so that we can have a picture, please.
Professor Dr. Sunil, please turn the video on. Yeah, it's got it.
Thank you all. Patience, persistence, and perspiration makes an unbeatable combination of success. I, Dr. Mika Mariam Sabu, on behalf of Pushpagiri College of Dental Sciences and Organizing Committee of OOO Conclave, would like to welcome you all present virtually to the valedictory function of 5th OOO Conclave 2023. Now, I would like to welcome Professor Dr. Ethan Thomas, sir, HOD Oral Medicine and Oral and Maxillofacial Surgery, Pushpagiri College of Dental Sciences, Honorable President of OOO Kerala Chapter, to address the delegates.
Hi, good afternoon. I think, yeah, it's time for noon time. I'm sure all of you have had a great, 2 days of interactive faculty lectures. We had eminent faculties to speak on various topics pertaining to all three the specialties for the past 2 days. And I'm sure all the delegates as well as postgraduate students and even the undergraduate students have utilized this OOO platform to showcase their talents in presenting papers and posters. We did have an enormous response in terms of registrations over 550 and paper presentations about 250 papers presentations. And overall, it has been a very good effort taken by the Pushpagiri College of Dental Sciences. So on behalf of the OOO Kerala State Chapter, I would like to appreciate. In fact, they've done a very good job. Dr. Sunil, the Honorary Secretary of OOO Kerala State, will officially thank all and express his gratitude for all the contributions done by each and everyone. But great efforts, the team Pushpagiri for bringing up such a very great show, which is beneficial for all of us. And with that, we'll move on to the next part, like the much awaited part, the results declaration, the paper presentations and awards. Over to you, Mika, for the further proceedings.
Thank you, sir. Now I invite Dr. Charlene Sarah Babu, Organizing Secretary of 5th OOO Conclave, to announce the prizes of the scientific presentation.
No.
Yeah, it's coming up, Sunil. Yeah.
The scientific paper presentation under the faculty category from the Department of Oral Medicine and Radiology. The first prize goes to Dr. M. Chitrarasu. Second prize go to Dr. Srikanth P. Kunjumal. And third prize is shared between Dr. Dhaval Niranjan. Under the Department of Oral and Maxillofacial Surgery, the first prize goes to Dr. Sara Paul. Second prize, Dr. Pooja Chandrasekhar Sulgande, and the third prize to Dr. K. Ramesh. Under the Department of Oral and Maxillofacial Pathology, the first prize goes to Dr. Priyanka Madhavan, second prize to Dr. Dominic Agustin, and the third prize to Dr. Nisha Sam. Under the postgraduate category, All Medicine and Radiology, first prize goes to Dr. Snifa V.S., second prize to Dr. Lakshmi B., and the third prize to Dr. Rickson Wangmo. Under Oral and Maxillofacial Surgery, first prize goes to Dr. Adarsh Chowdhury, second to Dr. Saptasri Dey, and third to Dr. Ravindra Reddy. Under Oral and Maxillofacial Pathology, the first prize goes to Dr. Harsha Karwa, second to Dr. Renuka S., and third to Dr. Riya Varghese. Under the undergraduate category, paper presentations, the Oral Medicine and Radiology, the first prize goes to Selma Shanavas, second prize to Deslin Darley John, and third prize to J. Sahay Emmanuel. Under Oral and Maxillofacial Surgery, the first prize to Anam HN, second prize to Shivadat RP, and third prize to Sandra Arun. Under Oral and Maxillofacial Pathology, the first prize to Sara Tungiwala, second prize to Christina Pereira, and the third prize to Meher Singh Mali. Undergraduate poster presentation category, under the Oral Medicine and Radiology, the first prize goes to Divashri S., second to Janvi N.K., and the third prize to Akshada R. Under Oral and Maxillofacial Pathology, the first prize goes to Dr. Ashik Thomas, second prize to Dr. Adra M. Alex, and third prize to Ojasin Khanna. Congratulations all.
It's my privilege to invite Professor Dr. Sunil S., Head of the Department, Oral and Maxillofacial Pathology, Vice Principal Academics, Pushpagiri College of Dental Sciences, President, Karaday Society for Oral and Maxillofacial Pathologists, and Secretary of OOO Conclave Kerala Chapter for Board of Science.
Very good afternoon, all of you. Respected delegates, thus we are coming to the end of the 5th OOO Conclave. We are overwhelmed by the responses we received when we started out with the OOO conference. This is the 5th year the OOO chapter is organizing an annual conference, and this year we have had more than 550 registrations, and we have about 270 paper presentations or scientific deliberations here. We are happy to know that the faculties, the postgraduate students and undergraduate students from different states of India have actively participated in this conference. This year, when we planned of selecting the keynote speakers, we thought being in the online platform, overcoming the barrier of regional restrictions, we could include the international experts from the states and from the national level. We are very happy to have Dr. Reggie Matthew, Dr. Shankar Gowda, Dr. Ranganathan sir, Dr. Devi Kiran, Dr. Bobby John, and Dr. Sudhesh. I'm sure that all delegates had a very fruitful scientific session during the keynote sessions. And because of the over response of the scientific presentations, since we couldn't accommodate in these 2 days, we have to have a pre-scientific paper session on the 8th of March. I appreciate the scientific committee led by Dr. Shalin Babu for speculatively scheduled scientific presentations. We have had the scientific presentation in 4 or 5 parallel sessions so that we could all the paper presentations, all poster presentations from the faculty, the postgraduate and undergraduate categories. I'm more happy to say that all the presentations done by the delegates were equally good. And as our president was telling, it was a very tough time to select the best papers. But as part of the competition, we have to give only, we could only select 3 from each category. I take this opportunity to congratulate all the participants and all the winners of the paper poster presentations of all the categories. I take this opportunity to thank the management of Pushpagiri College of Dental Sciences for permitting us to organize the 5th OOO Conclave on the virtual platform. I thank and acknowledge the Association of Stomatologists and Imagologists of Kerala, and the President, Dr. Beena Verma, and Secretary, Dr. Diva MS, for collaborating with us. I also acknowledge and thank the Association of Oral and Maxillofacial Surgeons of India, Kerala, the President, Dr. Arun Babu, and Secretary, Dr. Akhilesh Pradhav, for collaborating in the 5th OOO Conference. I take this opportunity to thank the Kairali Society of Oral and Maxillofacial Pathologists, the Secretary, Dr. Mahija Janardhanan, for collaborating with this 5th OOO Conclave. Then I should thank the IT team of Pushpagiri College of Dental Sciences, Mr. Marvin and Mr. Jijin, for spending and sparing their time throughout with us during these 3 days. Then I should thank the organizing team members from the 3 specialties, Department of Medicine and Radiology, led by Dr. Anuna Madam, Dr. Anju Madam, Dr. Lisa Madam, and Dr. Irene Madam. From the Department of Oral Surgery, along with Ipin sir, Akhilesh sir, Vinesh sir, Dr. Devi, and Dr. Alan. From the Department of Oral Pathology, along with me, Dr. Shalin Sara, Dr. Tivin KPB, and Dr. Sunu. It was a wonderful time which we have spent to organize this conclave. Now, my dear students, from 1st year, 2nd year, 3rd year, final years, and interns, actually they are the backbone of our team. I take this opportunity to acknowledge and thank each one of the organizing team for having a wonderful time here. And at last, our MC, Dr. Meega Medisavu, she has done a wonderful job. She has been sitting all these 2 days throughout with us for speculatively organizing and scheduling the programs in time. And before I wind up, I once again thank all the dear participants from all over India for again joining us in this 5th OOO Conclave. Thank you all.
Thank you, sir. Now let us all rise for the national anthem.
Thank you. Thank you so much, everyone. Kindly share your feedbacks in the group so that we can actually improve better in our upcoming conferences. Thank you so much. Thank you all.